You can sit there. And I just disconnected. Yeah. I think there are 2-3 rows of
Hi there, I'm Dr. Michelle.
Hear me? Good morning, friends. So we'll start the HFI 2023 quiz. Yesterday we had the preliminary rounds, which was well appreciated, and we had a good number of participation. We have selected 4 teams based on the prelims. They are Dr. Praveen M and Dr. Devesh Kumar from AIMS, New Delhi. Can you come forward and take the lots? There will be 4 teams, A, B, C and D. Depending upon the lots, you can get, the team A will sit here. Team A is AIMS, New Delhi. Next is Madras Medical College, Dr. B. Lakshmi Narayanan and B. Surya Narayanan. He presented the case in the clinical case discussion. I think you remember them. Remember him. Team number C, Team C. Sorry. Yeah. Next is Madras Medical Mission Hospital, Pradeep Chowdhury and Saukara Rao. Yeah. Get your. Now next team is Ushni Shadigari and Swasti S. Kumar. I think you don't have any choice. You have to sit on team B slot. Okay, I invite Dr. Chopra as he is adjudicator along with Dr. Abraham Oman. Dr. Abraham Oman is busy with the organizers. He will join. Sit there. And I also invite Dr. Sajan and Dr. Arun also to join the dais, and Dr. Vijay will be the scorer. I think Vijay will be sitting there. Yeah, okay, wherever you are. Yeah. So congratulations to the winners. I will tell you the rules of the quiz. Can you see? Yeah. There will be 7 rounds. The first round will be history. There will be 3 general rounds. Out of the general round, the first one will be something called connect. Abraham, please join. The 2 will be general rounds and 3 will be Jeopardy rounds. I will explain what it is. And midway after the 4th round, it will be reversed. Okay. So those 7 rounds, all the first 3 rounds will have 20 marks. No negative marks. It will be passed to the next team also. If the question is passed, the same marks will be given to the next team because the first team is not answering and they are better than the next team. That is why. So we thought we'll give the same marks. The Jeopardy round will have questions with 3 levels of hardness. will be plus 30, plus 20 and plus 10. You can choose. You can choose any of the three. This thing in all the three rounds, and there will be negative marks. You have to take a question and there will be negative marks even if you answer or not. So that will finally decide the winner, as usual in our previous quizzes also it has happened. I think if you have any doubt, you can you test your mics please? Team A. Can you put on their mics please?
Hello? Yes, sir. I think I'm audible.
Team B.
Hello.
Team C.
Hello.
Okay.
Hello.
Okay. Scorer, your mic is also okay? Okay. So, shall we move? Sir? First round is history round. First question is to Team A. Who is the first documented case of acute decompensated heart failure? Need not tell the name, but you can tell the entity. First documented, scientifically documented case of acute decompensated heart failure. Just in the newspapers and all. Scientific literature also it is there. No negative, you can guess also.
It was Hippocrates patient.
No, sorry. Team B.
Some pharaoh, Tutankhamen or somebody, pharaoh from Egypt.
Not Pharaoh, but something connected.
What is that lady?
Some Egyptian mummy.
Egyptian mummy, that is an Egyptian mummy. So this is the first documented case of heart failure. It is called Nebri. This person's body, 3,500 years old person's body was preserved. The lung was actually well preserved, and they did a histological analysis and found that there was no parasitical or any other infections. So they said the lung was full of fluid, and they documented it as acute decompensation of heart failure due to hypertension, due to other changes in other organs. So that is a question number 1. Question number 2. They get 20 marks. Team B will get 20 marks. Question number 2 to Team B. These are brothers. As kids, they built an ECG machine out of old radio parts, and later when Adrian became a doctor and Arthur a professor of engineering physics, they paved the way for many modern day gadgets. Name the 2 gadgets which essentially heart failure specialists use. Brothers. Adrian and Arthur.
One is echocardiogram.
Sorry? It goes to, not echo. Not echo. Goes to Team C.
One is LV assist devices.
Not LV assist device. 2 very important devices name. Team D.
Pacemaker.
Sorry. Team A. When you hear the second name, you will suddenly remember this. Adrian and Arthur. It goes to the audience.
Total artificial heart and
Sorry. Audience, anybody? No. Goes to the quiz master. It is Kandrovitz brothers, Adrian and Arthur. They invented LVAD and intra-aortic balloon pump. ABP and LVAD. They answered. You said LVAD. Okay, they will give half the marks then. They will get 10 marks. Okay, go to Team C again. First large RCT in heart failure with survival endpoint. What was the first large randomized control trial in heart failure with survival endpoint? So when the first large randomized clinical trial in heart failure was conducted by John Cohn and others in 86, it showed that despite a short-term hemodynamic improvement, DASH therapy could prolong survival. Which is the trial? Which is the drug? First large RCT in heart failure. Drug is still being used.
Drug is a beta blocker.
Sorry, no. Drug is still being used. Trial name and 2 parts, 10 marks each.
Ramipril.
No. Sorry.
Digoxin.
Sorry. Anybody? Again, it goes to the quiz master. It is Hfai. Hfai, and the drug was hydralazine plus isosorbate dinitrate. That proved that vasodilators were helpful in prolonging survival. The first trial which showed that vasodilators prolong survival in heart failure. First trial. Then now the question goes to team D. Xenotransplantation, yesterday there was a question, what was the reason for the mortality in those patients in the prelims? You must have seen the answer also. So the question is, who did the first xenotransplantation in India?
Dr. Sen, Mumbai, 1958.
No, he did the first heart transplantation. Who did the first xenotransplantation in India? It was a controversy sometime back. It just came in the newspapers also. He did with the help of a surgeon from China. Team A, Team B, Team C. I think everybody is not exactly. Oh, sorry, I didn't ask the audience. It is Dr. Barua, Dhaniram Barua from Sonapur, Guwahati. He did a transplant, a pig heart into human with VSD. I don't know what was the indication, but he was subsequently jailed. And he did the help of a Chinese surgeon. So that is the round number 1. We'll come to the end of the history round. Now we'll go to the round number 2. That is general round. That is the connect round. Connect round. There will be some pictures where you need to connect and tell the answer. The questions will not be passed in this round, okay? Because there may be some clues. Question number to team A. Question number to team A. This intervention was pioneered by a cardiologist and a neurosurgeon in 1970. Preceded successful drug therapy for this disease. The figure shows the most common reported side effect of this intervention. Identify the intervention and the disease. So, side effect of the, so many clues are there. The intervention was pioneered by a cardiologist and a neurosurgeon. Figure shows the most common side effects. The side effect is actually, if you see the picture, you will identify what it is. Yeah, that is evident. But what is it? What is the intervention which can produce it? This is done as a, what is it? As a bailout, routinely done as a bailout in some situations. Shall I pass? Exactly, 20 points. 20 points. Left cardiac sympathetic denervation for long QT and CPVT also. Okay, so that is the answer. Okay, team A gets 20 points. Now we will go to the main side effects. You can see left-sided dryness, unilateral facial flush, hyperhidrosis. Okay. Yeah, question number 2. Connect these pictures and which essential drug in cardiology associated with these pictures. John Hopkins, 1916, somebody, some medical student, and some picture of some organ. I think it is always discussed in history. It's a very common drug, very you use every day. Every day, yeah, almost every day, yeah. I think you cannot live without this drug.
It's related to cardiology.
Exactly.
Aspirin.
In cardiology, you cannot live with it.
Aspirin.
Sorry, goes to wait. No. You will get your chance. Don't worry. No pass. Oh, sorry. No pass. Oh, that is fine. Okay, we can tell the answer. Sorry. Any of the other teams can answer. No. So, medical student invented. No, he has a problem with this. Dr. Howell, who was his supervisor, he invented from liver tissue of. Yes. Connected with the liver.
Name of it.
It is heparin. Heparin was invented by a medical student, J. McLean. So he invented it when he was a second year medical student working with Dr. John Howell. Then subsequently Dr. Howell tried to claim it, and there was some big issue. And that is what I said. You cannot live every day. You must be using heparin, no? So that is what that clue. John Hopkins. It was 1916. I think when we discuss history, it is always there. Yeah. Okay, shall we move to team C with question number, yeah. It's a poisonous Brazilian viper called mother-in-law snake because it strikes unprovoked. So the John Wayne, the Nobel Prize winner, he has done significant work in endothelium and prostacyclins. He developed the first among a group of drugs found to be effective in heart failure, working with the dog lungs. That is also a very common essential drug used in heart failure. What is it?
This is also related to cardiology.
Yeah, this is related to cardiology. Yeah. Heart failure. So I think 90% of the questions are related to heart failure. Mother-in-law snake. Yeah. Who is team C, no? Yeah. One of the early group of drugs working on dog lungs. Some clues are there. This derived from viper, working on dog lungs. Something connected to lungs. Can you go to? No nitrates, not nitrate. Team A. Oh, this is not pass, no? This is no pass. Not AC, which is inhibitor? Captopril. Exactly. You will not get the marks, but it is captopril. It is captopril. So that is what he started. Actually, the Bristol Myers Squibb, the huge company, was actually started by this particular discovery. Okay, we'll go to team D, no? Last question of the rounds. Okay. 43-year-old lady with history of cardiac surgery and surgery for pituitary adenoma. Connect and diagnose. Connect and diagnose. 43-year-old lady with this clinical picture. She has a clinical picture. And echo shows something. She had a history of cardiac surgery and surgery for pituitary adenoma. Very classical something.
Tuberous sclerosis.
I didn't hear you. Can you?
Tuberous sclerosis.
Sorry, not tuberous sclerosis.
Carney complex.
Carney complex, exactly. This Carney complex. This patient is our patient who had a recurrence of myxoma. Carney, there can be recurrence, and she had a pituitary tumor, which is very classical. And see, this is the Carney complex. She had a previous surgery for myxoma recurrence and a pituitary adenoma also, and she presented with this. So with this, we come to the end of this session. Scores. Can you show the scores, please?
Team A 20 points, Team B 20 points, Team C 10, and Team D are going to open their account.
Now we'll go to the general round 1.
Yeah, we have to reverse the order, sir. After 2 rounds.
2 rounds at reverse, okay. Or or we want to reverse it now, we can do, because there are 7 rounds, and then it will be problem. I think we'll reverse after this round, okay, 3rd round. Okay. General round 1. So this is a classification of a particular disease, and based on this imaging, they decide on the intervention of this particular disease. What is this?
This round there is passing.
This round is passing. This round it will pass. Team A again. It's an imaging of a particular condition where the treatment modality will be decided. The success of the treatment modality will be decided by this type of imaging. What is it? It's an emerging. What is it? It is Team A. OCT images, that everybody knows. Sorry, it's not. Team B.
Coronary dissection.
Sorry.
Woven coronary arteries. Woven coronary arteries.
Bovine coronaries. No.
Woven, W-O-V.
Woven coronary. No, it's not coronary. I can give you another clue. It's not coronary. Team D. Some other disease where the emerging treatment modality is being done. Size is larger, no? Larger than coronary. 5 millimeters. Okay, shall we, in audience, anybody? Pulmonary thrombosis, I think if you had the prize, I think Ambuj is getting all the prizes probably. Yeah, so, CTF, yeah. This side. Pulmonary artery, based on the imaging, we decide on whether the success balloon pulmonary angioplasty, whether it is successful. That is decided on this type of imaging. Very small thick wall can yield, the other ones will not yield. Okay. Question number 2 in this round goes to team B. 38-year-old male patient presented with chest pain after celebrating his success at stock market. 38-year-old male, coronary angiogram and LV angiogram is shown. I want the exact answer. Read the history also.
Happy heart syndrome.
Exactly, happy heart syndrome, 20 points. Happy heart syndrome. It is also called what? There is some other
Reverse Takotsubo.
Reverse Takotsubo or mid Takotsubo, whatever. There is another name connected with the Greek mythology.
That is not reverse Takotsubo.
That is not,
No, that is not reverse Takotsubo.
Not reverse Takotsubo, yeah. This is not reverse Takotsubo, this is mid Takotsubo. I given in negative marks, but it's happy heart syndrome. It's also called Diagoras syndrome. Diagoras was a Greek athlete. He had won so many years in athletics in this Olympics, that ancient Olympics. Then finally his 2 sons also were successful, and the 2 sons carried him while he was in that podium. So somebody suggested that this is the best moment in life, that if he dies, this is the best in his life, and he immediately collapsed and died. So that is the Diagoras. It is also called Diagoras Takotsubo happy heart syndrome. I think there are different. I think it is male predominance, atypical presentations like that. Okay, team C. What is a mutation associated with the dilated cardiomyopathy, which has increased risk of conduction system diseases and ventricular arrhythmias?
Laminin.
Very good, 20 marks. Laminin mutation, that is lamin or LMNA, that is 20 marks. Now the question goes to team D. What is your diagnosis? There cannot be any other diagnosis.
Ventricular free wall rupture.
Free wall rupture, exactly 20 points. ventricular free wall rupture. This is one of our patients who collapsed in the OPD. We brought immediately and did this, and we found this, and patient couldn't survive. This is, okay, now we will go to the next round. So that is the general round 2, no? General round 2. That is something on devices and techniques. Devices on and techniques. Yeah. So again it goes to, now we will reverse. Now we will reverse.
Yes, sir.
Reverse. Team D. Team D. Something on new devices. What is this intervention? How it benefits heart failure with reduced ejection fraction? It's a new device which is coming up.
Baroreceptor
Exactly,
stimulation.
baroreceptor stimulation, 20 points. Baroreceptor stimulation, 20 points. Carotid baroreceptor stimulation, it inhibits the sympathetic activity and enhances the parasympathetic activity. That is how it works. Carotid baroreceptor stimulation. Now team C, no? Yeah. What is this device? What is the mechanism of benefit? What is this device? What is the mechanism of benefit?
Coronary sinus occlusion.
Coronary sinus?
Flow regulator.
Flow? Yeah. Flow?
Regulator.
Regulator, exactly. It is coronary sinus flow regulator, 20 points to team C. So it is used for refractory angina, but it has been found to improve the LV function also. Coronary sinus reducer or coronary sinus flow regulator. So this is called a Robin Hood effect. It redistributes the coronary flow and improves the outcome of patients. So coronary sinus reducer. Now it goes to team B, no? Yeah. What is this intervention? What is this intervention? Something with multiple electrodes are being done in some place. Can give it the catheter position also will give a clue. You have any answer? Team B. No negative marks. You can attempt. No.
AF ablation.
AF, no, sorry. No, pulmonary, not pulmonary, vein isolation. Teams D. Team C.
Delay appendix.
Huh?
Atrial flutter with the KO tricuspid stimulus.
Can you speak louder?
They said atrial fibrillation.
Not atrial fibrillation. Anybody from the crowd? It's pulmonary artery denervation for severe pulmonary arterial hypertension, which is an emerging modality of treatment. Pulmonary artery dilatation for both pre and post capillary pulmonary hypertension. So this is that multiple electrode catheter which is used. I think this was a question in the last quiz also. I think people should follow the quizzes, otherwise you will miss the marks. Okay, now the question is to team A. What is the dreaded complication very specific to this intervention? Some intervention is being done, but this is very specific to that. Exactly. Exactly, it is pulmonary. It is pulmonary overperfusion. Exactly, very good answer. 20 marks to team A. 20 marks to team A. Very good. That is all the specific to this intervention. The other hemorrhage, dissection, and all will be common, but this is very specific. So now the general rounds are over. Now we will go to the Jeopardy scores. Can you have the scores, please?
Can you show? Yeah. Team A 40 points, Team B 40 points, Team C 50 points, and Team D 40 points.
So very neck to neck race. I think the Jeopardy will have a compulsory negative marks. So be very careful. Perfect scenario for the tie. There is a super over when there is a tie. So with the bouncers and off cutters, etc. So be ready for the tiebreaker in case. Yeah, Jeopardy starts. Yeah, I think we can have one round here and two round other way. I think I will go to the Jeopardy. Jeopardy, I will explain what it is. Yeah, Jeopardy round is like this. I think you must have seen. There are three rounds of NYHA 1, 2, 3 and 4. So depending upon the intensity of the disease. So 10, these are all less tough questions, the medium tough and really tough. The advantage is that you will get the answer, you will get 30 points. If you don't answer, or if you attempt, you don't answer also, you will, or negative wrong answer, you will get minus 15. Minus 15, minus 10 and minus 5. Okay, now start with the team D. You can select anyone. It is nothing. You can select any of this. Out of these 12 questions, you can select any question.
Very democratic round.
Yeah, it is a democracy.
10D, sir. 10.
So
NYHA
you
class
are playing safe. You are not taking a risk. Okay. 10?
D.
10D. Okay, 10D. Okay. It's an instrument or device used in cardiology. This person who has developed it is carrying this equipment. Here he tested atom bomb for the US military. There are 3 landmarks in USA in his family name: a dam, an art museum and a lake. Identify the person. Routinely used equipment in. This will not be passed. This will not be passed. It will directly go to the audience. It's carrying the equipment. That is a clue. He tested atom bomb. That is not a clue. Audience? Norman Holter. Norman Holter. So he is carrying that Holter equipment, and there is a art museum, a dam and a lake in his name. So now we will go back. Team C get the chance.
Team D get minus.
Minus 5. Yeah. Minus 5.
10C.
10C. Okay, you are going the reverse order. Okay. Yeah. Very classical angiographic findings of something. So you can diagnose. Very classical angiographic picture.
Stack on coin appearance. Stack on coin appearance on the.
I didn't get you.
Stack on coin appearance on the LV.
What is the diagnosis? The appearance you have described, but what is it? Coin of stack appearance, you said.
Yeah, non-compaction of the
arithmogenic. What should we do? Stack of coin you said, but what is it classical of?
ARVD.
No, what can you said? We will give no negative. We will give 5 marks to them. 5 marks to them. Stack of coin, ARVD. Yeah. Yeah. Anyway, so we'll go back to okay. Team B.
10B.
10B. Okay. Everybody is playing safe. Okay. The roots of SGLT inhibition. So these are the 2 people who have developed the disease. Which compound discovered 150 years ago is mentioned here. There's some clue in the picture also. Something at the base, roots of SGLT inhibition. Roots of SGLT inhibition. Yeah, it's apple tree.
Apple tree. Cedar. Some,
SGLT inhibition.
dapagliflozin was discovered from that apple.
Yeah, but I want which compound discovered 150 years ago is mentioned. Dapagliflozin, not the gliflozin. That is what SGLT2 inhibition. What is that compound name? Goes to the audience. Fluorescein, exactly. Fluorescein is the compound where it was, but it was not usable because of because it is a non-selective inhibitor. So it produces much side effects in the gastrointestinal system. It came from the root of it was isolated in 1835. At that time, itself is found to reduce blood sugar, but cannot be taken orally, poorly absorbed, etc. So that is it. Fluorescein, that is the basis of team A. Minus, they will get -5. Yeah. -10A. Okay. Anyway, you have to take the 30 questions also, either now or later. What is this intervention? So many clues are there. The wire, the injection, the balloon. What is that called? I'll give you the marks, but tell me. Run where? For what? For what it is done? Pericardial run, I agree. Can you improve? No. What is that? Not in CCP. Where is not exactly in CCP? Where will the fluid drain? Peritoneal cavity. What is that called? Not shunt. It's a pericardial window. Window of the pericardium. Exactly. They will get the marks. 10 marks. It's a pericardial window. Percutaneous pericardial window. Creation of a percutaneous pericardial window for refractory effusions, etc. So, okay. Now we will again go to team D. Scores. Yeah. Can you show the scores?
Can you show?
Getting tougher or?
Team A 50 points, Team B 35, Team C 55, Team D 35.
Okay. Now, yeah. Okay. Next round starts with team. Can you come back? Yeah.
20B.
20B. 20B. What is your diagnosis? Again, a classical angio finding. What is that angiogram showing? Classical of some disease. Anyway, you will get negative marks even if you say a wrong answer. That is okay. Anyway, you will get -10 if you don't answer, but you can attempt. So not. I thought it was not that difficult. You can attempt something, no? Okay, it goes to the audience. Not EMF.
Karthikeyan, you are telling.
So there will be non-compaction. It's LV non-compaction with wall motion abnormality. There is filling up to the apex, that is why it is not EMF. Okay, team C.
20 Cs.
20C. Tell me the full diagnosis. Tell me the full diagnosis. It's also classical of something. Yeah, cannot.
1 minute.
Yeah. See the angio in full. I think your time is running out.
PR, pulmonary problem.
I think it
So
is.
supracardiac, PAP.
So PAP we seen, absolutely no. Biventricular EMF. Biventricular EMF. You can see the RV angio, the apex is not at all filling. I will show you the answer. But you can see that in the levo phase, the LV was filling actually. You can see that. You can see that apex is cut off. No, it is biventricular EMF. So they will get -10. -10. Okay. Huh? This was operated for the. I think it was a recurrence of EMF only. Recurrence of EMF. Yes, team B.
20A.
20A. This is a new device which has come to India. It was initially used by the the Israel military for seeing the terrorist hiding behind walls. Using a RF technology, radar technology. Now the device has come to India. Many hospitals have it. Thermo is marketing it. What is that device? It is for monitoring heart failure. I can give another clue. Using RF technology.
Non-invasive monitoring of volume status.
That is true. But what is a device? This device was in our hospital for 2 months in CCU and all. Yesterday it was presented here also by who presented? I think presented in this hall also. Presented there. I think you presented. One slide you showed. If you have attended that PG session, I think most of the questions are from the sessions only. I think he presented that. He made a passing mention of this. Okay, I think.
Wall
Yeah,
impedance monitor, that wall impedance monitor, the cardiac impedance monitoring.
not impedance actually, it is fluid monitoring, but that you said. So what should we give negative, or they said some fluid, or we should not give negative? Adjudicator can decide. Negative.
Yeah, don't have
Okay,
a time.
-10. -10. So this is called a RETS device. This has come to many hospitals in India. This device was in, I think they are demonstrating in all hospitals. This was in my hospital for some time. I think you should have seen it. Anyway, okay. Now we will go to The yes, you want to go 20D? There is no rule that you can take 30 also. Don't want. Okay. What are the devices this patient is having?
So there is a subcutaneous ICD and there is a CCA.
Exactly 20 points. 20 points. Subcutaneous ICD and CCM. Exactly. Yesterday, I think if you had attended this session, you would get it. Okay, now we'll see the marks.
Team A 70 points, Team B 25, Team C 45, Team D 25.
So anything can change. I think 30 marks can make a lot of difference. So I think like the election counting, it can make sudden changes in the fortune. Okay, now we'll reverse around. No? Yeah, they want to see the scores. There will be a super over, don't worry. If there is a tie. But if you the team A scores minus and the other team scores a positive, then this will reverse. So be careful.
All
Okay,
questions
now-
are NVHA 4, so strategy is not.
Yeah,
going to change.
they are going very as the heart failure worsens. Okay, so yeah, team A, you are ready? You are ready? You have decided. Okay, we'll test 30B.
LVAD, patient is on a LVAD.
Exactly 30 points. 30 points. Can you describe it?
So basically the patient, there is no BP trace because it is a non-pulsatile device.
Okay.
You're not getting a pulsatile.
What is the ECG?
The ECG is, it's not the ECG.
It is the ECG only. That is the clue. I think whether we should take negative marks, I don't
Explain
know.
and then you will
Don't
have
explain
questions.
and get into trouble. I thought you had, the patient is in ventricular fibrillation, but still you are getting a BP. Yeah, that is what. Then should we don't explain and get into trouble. So I thought you had the clue, and because that is a question. ECG is in VF, but patient is getting an nearly 100 mean blood pressure. That was the question actually. Okay, anyway, we are not taking back the marks.
He said non-pulsatile.
That is okay. That is okay. Now, yeah, team B,
30D.
30D. Yeah, okay. Think, what are you visualizing? This is got from Twitter. I am thanking that person. Patient with severe heart failure on supports.
It's a transesophageal echo showing LV outflow and aortic valve. That is.
Okay.
Yes, sir.
Yeah, correct. What are you seeing and what the patient is heart failure on supports. What support? What is it?
It is in the aortic ascending aorta.
Okay.
There is a device that is.
There is no device. There is no device in the ascending aorta.
There is a mass that is obstructing the outflow.
Is it a mass or something else?
Cannula that is placed.
I think minus 15. Now we'll give 5 more seconds to give something. Okay, audience? Not clot. It's aortic stasis in a VA ECMO. When there is a patient is on VA ECMO, there is no forward flow. and this is a very significant complication of this VA ECMO. When the aortic valve don't open actually, because the heart is so, the pump, this thing is this depressed. Okay, minus 15. Team C.
30 Cs.
30C. What are you seeing and what is it?
So, bypass, 2 impellers.
Exactly, how much? 30 marks. Biventricular support by impeller RP and usual or LV impeller. Impeller RP and okay. Yes, you have no choice to go to 30A. Yeah, I'll open it for you. 17 years old boy, born blue, and had 2 planned sequential surgeries in childhood. You might have got the clue. Developed persistent cough and he coughed out this. What is your diagnosis? You got a clue from that what I have written. 17-year-old boy born blue and 2 planned sequential surgeries. That indicates something.
Pulmonary thrombus.
Not thrombus. What is it? You coughed out. No, don't Evels means what? It coughed out this. It's a non-complication of this particular procedure which you have described. What the procedure the patient has undergone? Anyway, the question is open.
Plastic bronchitis.
Plastic bronchitis, exactly. That is plastic bronchitis, a complication of Fontan. Rare but serious clinical condition commonly seen after Fontan surgeries in children, may be a manifestation of suboptimal adaptation to the unfavorable hemodynamics. So lymphatic flow disorder actually. Okay, now we'll see the scores, and if there require a super over, then we'll go to super over.
So Team A, Ames New Delhi, 100 points, followed by Team C, Madras Medical College, 75, and rest Team B and Team D have tied.
I think they scored badly in the Jeopardy round, that is why. Okay. Anyway, congratulations to the winners, Team Ames Delhi and Madras Medical College. Congratulations. And the Team A will get 75,000 or 50,000 rupees as prize, and the second team will get 25,000. And the certificates also.
He's made a killing. He got 150,000 yesterday also.
Yeah. I think we should cut something as a
TDS.
We can contribute something to Heart Failure Association back.
25% deduction.
Yeah.
Congratulations.
Yeah, I think he got the best paper award also. Anyway, thank you for joining, and we'll go to the next session. Thank you. And I thank our Arun, Sajan and Vijay for the prelims yesterday. It was, I think you can, the participants will know that how educative it was. I think we should conduct it in a session where there are people. I think we take so much effort.
It's very interesting. I think everybody would
take
enjoy
so much effort, and is educative, and only very few people. Okay, thank you so much.
9:30 we would start the next session. So please stay on. There are some very, very interesting talks and interesting sessions. Meanwhile, you can have some coffee outside.
The team who won and the runner-up, the members, please come on stage for a group photo with the moderators.
Initial plan was to do it 8 to 9, no? That is what he told me. Yes, okay. Next year, give us in Delhi, no? Give us a prime time.
Yeah.
Dinner.
So, joint session just before lunch, that is important. And this should come.
dysphagia. What was the most common cause of death in this condition? Patient is not in cardiology, she's in dermatology, but she has history of dyspnea and dysphagia. Anybody? The condition? Yeah. Systemic sclerosis or scleroderma. We should understand that PH is the leading cause of death and affects up to 12% of patients. There is a 50% mortality if there is severe PH within 3 years. This is a 45-year-old male who was evaluated for bilateral lower limb edema, swelling of both feet, and it was relieved subsequently with a treatment. What was the treatment done?
The treatment is shown.
The treatment is shown.
What is the treatment?
Yeah, you can see a stent there in the IVC. So IVC obstruction which was stented, and symptoms got relieved. This, of course, very famous picture now. But what was the cause of the transplant failure, unfortunately, which happened 2 months after the... What happened? Not diastolic heart failure. Porcine CMV infection of the graft. So we always used to learn about CMV and how it accelerates atherosclerosis in the transplant heart. It can also be a cause for failure of the transplanted heart. So this is the newer interventional system that is depicted, and the clue is there in the Range Rover that is there. And not mine, sir.
The fluoroscopy images tell that the intervention is done.
Yeah.
The intervention is done on one particular aspect of the heart. Where?
Couple of teams had written the answer also yesterday.
It is done on the?
It is a femoral transcatheter tricuspid valve replacement. The system is called the Evoque, which is a Range Rover's vehicle. Range Rover Evoque. Yeah. Ethanol infusion into which vein is tried in the treatment of AF or atrial tachyarrhythmias? We know that we use it for HOCM, alcohol, but it has got other uses in cardiology too. So which particular vein is used? Yeah. I am talking about cardiac uses of alcohol, not non-inebriatory uses of. It is the vein of Marshall where alcohol is injected. It has been tried for atrial tachyarrhythmia. 3 images are given. We have to link and diagnose the condition. Anybody? Simple, I think. Yeah, you can see a non-caseating granuloma, ventricular tachycardia, and complete heart block, which can be seen in cardiac sarcoidosis. This is a lady with heart failure detected 1 month after delivery. You can see the severely depressed LV function. So which drug should be co-administered along with bromocriptine? Yeah, very good, excellent. So this is the board algorithm from the ESC. So whenever we give bromocriptine, patient has to be on anticoagulation because bromocriptine can produce the thrombosis. This is a simple one. Yeah, you can see the apple green birefringence and the thickening of the intraatrial septum and the left ventricular hypertrophies, cardiac amyloidosis. Okay, this is a recent trial. Which drug used in ophthalmology practice was found to be beneficial in acute decompensated heart failure? Yeah, correct. So IV acetazolamide in ADHF with volume overload. Mavacamten also we had discussed yesterday, black box, but there is a black box warning for mavacamten for this myosin inhibitor. What is the black box warning for? You can't say heart failure because that's, yeah, you have to be more specific. The ejection fraction should be more than 55% because it can inhibit contractility. So we have to interrupt when we monitor. If the EF falls below 50%, we have to stop the treatment. Okay, this is the one on the left is the echo of newborn at birth. Then the last one is at 4 months when things have improved, and you can see the evolution. So what is this reversible condition where child has significant left ventricular hypertrophy? Yes. Correct. It's an infant of diabetic mother, so there can be reversible hypertrophy. We have two athletes here with both having left ventricular hypertrophy on echocardiogram, both having normal ejection fraction, but athlete number 2 was not allowed to participate in the sporting event by the organization. Why? So one is both are strain images, not scar formation. Of course, there is strain abnormality in one, both having LVH.
Specifically mentioned normal EF.
Normal EF and LVH, both are athletes. One is having strain abnormality, the other the strain is normal. And okay, I'll give a clue. The athlete 2 was dishonorably discharged from the competition.
That is Dr. Sargent intends to tell that this is probably the investigation you should do when somebody comes to you for pre-athletic clearance or something.
Steroid abuse.
Okay. So it is anabolic androgenic steroid abuse, doping in power athletes. Both will have, because we know athletes will have left ventricular hypertrophy. They will have normal strain in endurance athletes, but in the other person there was reduced strain, diffuse involvement. So we have to be on our toes. This is a dog experiment, a pretty old one. Name the principle responsible for this phenomenon. You can see saline infusion being done, and at the end of the infusion, the change in the QRS voltage. The QRS voltage has increased. What is the name of this principle or effect, which we used to learn in cardiac physiology, basically? Not Frank Starling. It is called the Brody effect. It's called the Brody effect. Gut microbiome. This is Harikrishnan sir's favorite area. He had written an article in our newsletter also. So gut microbiome and cardiovascular disease, which bacterial product is mainly responsible? Now, gut microbiome has come up in a big way in almost every field of medicine. So which bacterial product is thought to regulate the adverse? Yeah, correct, excellent. So it is trimethylamine oxide. So that is what causes the lipopolysaccharide leakage and systemic inflammation and effects. This is a 40-year-old lady who had acute pulmonary edema. I was admitted to the cardiac ICU on an emergency basis. She was on ventilator. Subsequently, her cardiac status improved. You can see the echo Takotsubo-like picture on the left and full recovery on the right. But unfortunately, we were not able to take the patient off the ventilator, and meanwhile, she had neurological involvement with quadriparesis and diplopia. ABG showed persistent hypercarbia and respiratory acidosis. So we were in a fix because LV has improved, but we are not able to take out the patient off the ventilator. So an antibody test ordered by the neurologist, thankfully for me, in my case, my wife, helped in the diagnosis of which condition. Yeah, correct, excellent. So the it is a myasthenic crisis and the anti-acetylcholine receptor antibody. So myasthenic crisis can present like Takotsubo syndrome because of the imbalance between the sympathetic and the parasympathetic systems. This is the last question for me. This is Lyme. No, Lyme doesn't produce this kind of involvement. It's different. What is the name of this new treatment method for heart failure with left ventricular aneurysm or scar? I think many of you understood the concept yesterday from the answers. This is called the Revivent system. It is less invasive ventricular enhancement in patients with heart failure, LV aneurysm and scar. It can be done totally surgically or as a hybrid approach, and the main trials are the Configure HS and the Alive trials. There is a titanium anchor and a tether which is made of a resin, and we can exclude the aneurysmally involved left ventricular portion and improve the cardiovascular hemodynamics. So thank you. I'll hand it over to Arun for the rest of the questions. Keep alive the spirit of cardiology. I think it's not about exam. You love cardiology from your heart.
So the heart rate threshold for permanent pacing for complete heart block with a structurally normal heart and no other problems with so if the QRS escape is narrow is, what is the heart rate? You have to pace when the heart rate is below 55 per minute. If the baby's heart rate is, if the baby has a heart disease, then the threshold will be 70 per minute. So if the baby doesn't have any heart disease, you can wait till the heart rate is 55. If the baby has any associated heart disease, the heart threshold is 70 per minute. So the oximetry data showing the saturations in the SVC, IVC, PA and aorta. How will you calculate the shunt fraction from this? What is the formula? What is the formula? Aorta minus mixed venous saturation divided by PV minus PA saturation. So that comes to 2.5:1. So what is this formula and what value does it give? Some people often know only the name of this name only, don't know the formula or never applied it. This is the PISA method, proximal isovelocity surface area method for calculating the mitral valve area. That is why you take that aliasing velocity and all. So what is this time interval that is marked? Contraction, isovolumetric contraction time. Very good. So that is the time interval that is marked. What is the cause of heart failure in this day 3 newborn? Sorry? No, it is not obstructed TAPVC. I did not. Where is this image taken? What structure is being imaged? It is the brain. This is a vein of Galen malformation. You see the brain and you see all the venous structures and the huge sinus you can see, that blue color, huge sinus. That is how you put the probe on the anterior fontanelle in a baby with heart failure. You see this, you know that this is vein of Galen malformation. So, what is the clinical sign that is seen on this bedside monitor? It is pulses alternance, yes. So only alternate beat is generating a pulse. And the pulses alternance, severe form of pulses alternance seen in severe LV dysfunction. So pulses alternance with the severe LV dysfunction. So often the pulse oximetry probe that is connected to the monitor gives a lot of information. Most of the pulse abnormalities, BIS variants, dicrotic pulse alternance, paradoxes can often be seen on the monitor. What is this echocardiographic parameter which was actually dealt with in more detail in the last national conference, which measures the percentage of change in LV volume from end diastole to the time of peak aortic velocity. It is not ejection fraction. Ejection fraction is from end diastole till end systole. This is a little earlier than that. So that is called dash ejection fraction. It is called first phase ejection fraction. Okay, that was dealt with in the last conference. What is the parameter that is calculated by the QE formula, that is mean LA pressure minus LVEDP by 2? That is the mean mitral valve gradient estimated by echo. Mean mitral valve area estimated by echo is mean LA pressure minus LVEDP by 2, or as a shortcut to the formula even on cath, you can use that. What is the cardiovascular therapeutic application of red yeast rice? It is an alternative to, it is a dietary method to reduce cholesterol. Reduces LDL by 29%, 26%. So that is red yeast rice. So what is the most common congenital heart disease associated with the CHARGE syndrome? CHARGE syndrome is tetralogy of Fallot. Okay, CHARGE syndrome, tetralogy of Fallot. What is the speed of the treadmill in stage 2 of Bruce protocol? I think you should know the Bruce protocol, stage 1, 2, 3, speed, inclination, all the things you should be thorough. And also the unit, certainly not meter per second, it is miles per hour. Okay, even if you can convert it to kilometers per hour is also good enough, but it is 2.5 miles per hour. What is the cause of heart failure in this fetus? This is a pulse Doppler taken at the inflow-outflow view. So you can see the regular aortic pulses, but the chaotic mitral inflow, suggestive of AV dissociation. This is how complete heart block is diagnosed in fetal echo. Okay, so this is fetal complete heart block. What is this formula that is used to calculate the LV ejection fraction, which none of us routinely use, but the echocardiographic machine does it for you every day and on every echo? This is dash formula. This is not Simpson. This is the Take-Calls formula. This is the Take-Calls formula. Okay, this is the Take-Calls formula. That is what is fed onto the for your M mode. No, when you put the M mode, this is the formula that the echocardiography machine applies. What is the mechanism of action of tafamidis? Yeah, it's in TTR amyloidosis. It stabilizes the tetramer and corrects the misfolding of the protein. So that's how it is. What is CRISPR? Abraham Womans's talk yesterday. That is upcoming revolution in cardiovascular therapeutics. Okay, so this is clustered regularly interspaced short palindromic repeats. It is developed from bacterial genomes, and that is used to alter the genetic expression, and it can be used to connect the phenotype of existing diseases, and it's being worked up in cardiomyopathies and all. It's already been applied in leukemia and multiple myeloma and all, and it is upcoming revolution in cardiomyopathies. So what is this echocardiographic sign which is routinely asked in the exam? This is not SAM. This is?
See the arrow mark.
The arrow mark tell you what it is. It is? What is that? Premature closure of the mitral valve. Mitral valve should be open throughout diastole. You see, it's closed very early in diastole. It is premature closure of the aortic valve due to very early elevation of LV diastolic pressures, typically described in severe aortic regurgitation. What is this principle without which heart failure conferences cannot, or any evaluation of heart failure you cannot think about? Frank-Starling law. Okay. What is this principle? Yeah, this is the Treppe effect or the Bowditch effect, heart rate dependent increase in tension. Over to Dr. Jyoti Vijay.
It's a very simple question. Largest protein in human body, titin. Identify the imaging modality. So you can see in lower, it is very clearly intracardiac echo is there. So it's a intracardiac echo. Identify the sheath. So the clue is that there is a lead inside, the pacemaker lead inside, and that is at an angle. So it's a physiological pacing sheath or his bundle pacing sheath. Identify the chamber filled with the contrast. This is a left atrium, but you can see that this is a post surgical case. In fact, you can see that amputated LA appendage also above. What is being measured? You see left atrium and this is strain graph. So it's a left atrial strain imaging. Identify this personality. He is in fact a painter. He is known for his artworks by the layman, and a cardiologist we know for his appearance. So is Salvador Dali for a inverted mustache sign or reverse tick sign in the Dali's effect. So connect these images for a common diagnosis. You have an echo, you have a spade, so this apical HCM. Identify this personality. Is very famous. In fact, he is responsible for the longest or first published cardiology text. It still continue to get published. Everyone has written, in fact, none of them has written a correct answer. Most common answer came was Braunwald, but he is not Braunwald. He is Hurst. So this is a Google Doodle in 2019. So this Eindhoven to commemorate his birthday. So the question is, what is the device which he has initially used? So that device also we can see. So it's a string galvanometer. Identify the therapy. So it's a cardiac contractile modulation. We get the clue is that it is 2 leads are in the RV only, and the impulse device. So this statement, you would never buy a car without taking it for a drive, because you want to know how the engine has performed while it was running. So same applies to human heart. So we want to make the people run or make people exercise and know their problems. So this is about Bruce protocol or stress exercise test, stress ECG. Last very simple question, identify the needle. It's a broken bro needle.
So thank you.
That table, sir.
Good morning to our distinguished delegates, ladies and gentlemen. In another 2 minutes, we'll start today's session.
Tambi.
Good morning, everybody. I think we'll start the session as usual, 2 minutes early. So there's only one announcement. One of the speakers is attending to one of the central government ministers or brother or something, so he's not able to make it. So usual Indian issue. So with that, I welcome Professor Stefan Anker, and a big thanks to him. It was his mother's 83rd birthday, and after that he came, and we had to understand that he came today early morning, reached here at around 2:30 a.m. and he's flying out tomorrow. So this is the pains people take for academics, and I think all of us should give a big hand. And Dr. Anker is a friend of India, a true friend of India, has been coming here, educating. So I think he deserves a standing ovation. So please get up and give him a standing ovation, please. Thank you very much. Thank you very much, sir, for coming, because not many here also would have come to a conference, traveling so much time just after a personal family function. So thank you very much for it. That's a commitment for education and his love for India, and has been here multiple times. So thank you very much. And the first session is Guideline Director Medical Therapy. Dr. Manoj cannot make it because he's doing a primary for one of very VVIPs. So other chairpersons are here: Dr. P.B. Jayagopal, Dr. Sajan Ahmed, Dr. N. Arun Kumar, and Vishal Rastogi, I think, is yet to come. We'll start on time. So Dr. Manoj is not there, so we have some more time for discussion. So over to the chairpersons and the moderators. Thank you very much.
Meeting in the year, and of course, guideline directed medical therapy is important. And we have the first presentation given by Dr. Lee. My patient got infected. I think that's not working. I need help. Okay, let's see.
Okay, good morning, everyone. My talk today is about at the end of GDMT, what you are going to do. That is my talk today. Well, for that, first of all, I have to define what is GDMT, because if you go into the literary sense of the word, it is guideline-directed medical therapy, which means it includes everything in the guidelines, and so I don't have anything to say at all. So I looked into the 2022 ACC-AHA guidelines and came out in the first take-home message. Guideline-directed medical therapy for heart failure includes 4 medication classes. That also includes SGLT2 inhibitors. So I presume GDMT is only these 4 group of drugs: ACE, ARNI, beta blockers, MRA, SGLT2 inhibitors. In other words, drugs that has been shown to improve survival in heart failure with reduced ejection fraction. So I will deal with those medications outside these 4 groups of drugs. Let me start with hydrolysine isosorbide dinitrate, which actually gets a good indication, class 1, level of evidence A, but only for African Americans with NYHA class 3 to 4, reduced ejection fraction on optimal medical therapy. It has been shown to improve symptoms and reduce morbidity and mortality. The reduced mortality, however, in the trials with these drugs were on patients treated with digoxin and diuretics, not on ACEI or beta blockers, which means this was done in the days before the present guideline-directed medical therapy came into being. However, even today, the guidelines say that the economic value is very high, especially for the African Americans. It provides high economic value, this group of drugs. But for the rest of the world, for us, it is only a weak indication, class 2B, level of evidence LD, limited data only. Current or previous symptomatic heart failure, not given first-line agents, either because of intolerance or renal insufficiency, it does reduce morbidity and mortality. So a very weak indication, class 2B. Let me come to ivabradine, which is probably one drug has got a better indication, class 2A, one randomized controlled trial. In symptomatic patients, stable heart failure, ejection fraction less than 35%, on GDMT, including beta blocker at maximal tolerated doses, and in sinus rhythm. So there are a lot of ifs and buts. The patient has to be symptomatic, heart failure with reduced ejection fraction, on maximally tolerated beta blockers, and still the heart rate is more than 70, and in sinus rhythm. It reduces heart failure hospitalizations and cardiovascular death. However, it must be remembered that in the randomized controlled trial, that is the SHIFT trial, only 25% of patients were on optimal dose of beta blocker. So the thing to remember about ivabradine is that one has to initiate beta blockers and up-titrate to the target doses, or at least the tolerable doses, before considering ivabradine. Well, good old digoxin, again, gets a class 2B indication. One randomized controlled trial is there, level of evidence BR. Symptomatic heart failure despite GDMT or unable to tolerate GDMT. It decreases hospitalization for heart failure. No effect on mortality, but it reduces hospitalization for heart failure. Only one large RCT. And it predated the current GDMT. That is the problem with most of these drugs, that the trials that were done were before GDMT. The current GDMT came into being. So it is reserved for those who remain symptomatic despite optimization of GDMT. The important thing about digoxin is to start at a low dose, because higher doses are rarely required, and it has been found that higher doses are directly related to the risk of death, independently associated with serum digoxin levels of more than 1.2 nanogram per liter. So start with low doses. And remember, the DIG trial also showed that if the patient is on digoxin and you withdraw digoxin, there is worsening of heart failure. So you need not start digoxin, but if the patient is already on digoxin, be careful when you withdraw the drug. Start with a low dose, 0.125, maximum 0.25, and even lower doses for the elderly, those with renal function, and who has a low lean body mass. The new drug, soluble guanylyl cyclase simulators, again class 2B, one randomized trial, in selected high-risk patients with recent worsening of heart failure on GDMT, it does reduce heart failure hospitalization and severe death, directly binds and stimulates soluble guanylyl cyclase and increase cyclic GMP production, vasodilatation, endothelial function improvement, reduction in fibrosis, remodeling of the heart. And the Victoria trial showed that the primary outcome was significantly reduced, cardiovascular death or heart failure hospitalization, but no, unfortunately, no effect on all-cause mortality. Revascularization for LAD, which we had discussed, for CAD, which we had discussed already, gets a strong indication, class 1, level of evidence B1 randomized trial in selected patients with heart failure, reduced ejection fraction, and suitable coronary anatomy, but only for surgically revascularized patients, because the STITCH trial showed that at the end of 10 years, there was reduction in mortality, but no reduction at the end of 5 years. So it is only surgical revascularization. Unfortunately, the new trial Revived showed that in patients who have viable myocardium, who have PCI suitable anatomy, PCI did not reduce event rate. So as at present, there is no indication for a PCI revascularization in patients unless they have angina to reduce symptoms of heart failure. Well, there are several other drugs. I will run through them. PUFA, omega-3 polyunsaturated supplementation, gets a class 2B, again, level of evidence, 1 randomized trial. Class 2 to 4 symptoms, reduce mortality and cardiovascular hospitalization, again, predated present GDMT. Potassium binders, very important because now we cannot give many patients RAS inhibitors because of high levels of potassium. So can you combine these two and continue with RAS inhibitors? Well, the benefits we still do not know, are uncertain. We should also think of some drugs which may be probably in the list of the patient's medicine list, and that is possibly worsening the heart failure. These are drugs which are class 3 but no benefits. Anticoagulation without a specific indication like VTE, AF, previous embolic event or cardioembolic source, not recommended. Vitamins, nutritional supplements, hormone therapy, not recommended, other than to correct deficiencies. And then you have dihydropyridine calcium channel blockers, no benefit, but if there is hypertension, despite GDMT, you are justified in starting nifedipine or amlodipine or such drugs. Now, these are drugs positively harmful, and so you should avoid these drugs in heart failure. Non-dihydropyridine calcium channel blockers, class 1C antiarrhythmics and dronedarone. The only antiarrhythmics are amiodarone and dofetilide, which have neutral effects, while quinidine and mexiletine not studied. And then you have DPP-4 inhibitors, saxagliptin, alogliptin, increasing the risk of heart failure hospitalization, and no evidence but commonly known drug NSAIDs. So when the patient is not improving on GDMT, make sure that the prescription does not contain any of these drugs, long list of drugs. Remember that among all these drugs, the only class 2A indication is ivabradine. All the rest are class 2B. As I said, isosorbide hydrolysine combination gets class 1 only in African Americans. A word about atrial fibrillation. Class 1A, if the patient has got a CHARTS-WAS score of more than 2 men and more than 3 women for chronic oral anticoagulation, and DOAC is recommended over warfarin. Whereas there is still a class 2A indication even if the patient has no other risk factors and only heart failure for chronic anticoagulation, because after all, heart failure itself is a prothrombotic stage. And last but not least, patient not improving with GDMT, maybe you are not treating the comorbidities. So look at the big list of comorbidities that has to be dealt with. Valvular heart disease, iron deficiency with or without anemia. We have sufficient data to treat iron deficiency. Uncontrolled hypertension, again another missed factor. Sleep disorders, don't forget about that. Uncontrolled diabetes. Chronic lung disease, a very common comorbidity with heart failure. Chronic kidney disease, of course, very important. Psychological problems, depression, anxiety, Alzheimer's, dementia. And don't forget to give influenza and pneumococcal vaccines when the patient is getting discharged. Another important way how you can reduce rehospitalization in patients who are already on GDMT. I am not going into these because these are different entities totally, ICD, CRT, LVADs, transplant. So I conclude here and thank you very much.
Thank you, Dr. Unni, for a very exhaustive, comprehensive overview of the therapy when the GDMT is not working. So one of the questions, I mean, you have enumerated everything there, particularly the comorbid conditions. Sometimes you tend to miss a lot of arrhythmias which are not very manifest. So I think perhaps atrial fibrillation, patient, when he presents to you, is in sinus rhythm, but then time and again he might be going into that. So I think, what is your take on that? So if they're not improving, is it worthwhile getting a Holter or an extended Holter, monitoring these patients to see whether that's the prime cause for the worsening heart failure?
No, I think a Holter should show that, because the indication for atrial fibrillation ablation in heart failure is if you are thinking that atrial fibrillation is the cause of heart failure, like an arrhythmia-induced cardiomyopathy, in which case it may not be very difficult to find out arrhythmia. Short episodes of AF are unlikely to be the cause of heart failure. Of course, you may have to anticoagulate these patients.
Wouldn't you say that with the current emphasis of getting people on guideline-directed medical therapy as quickly as possible, but not necessarily push everybody immediately to the highest dose, that the criticism that we gave in the past for the ivabradine studies, that only 25% were on optimized beta blocker therapy, maybe that criticism is no longer valid. Maybe today we should look at it differently because they were on beta blocker therapy.
I think one of the point will be if you start ivabradine and then you will not be able to raise the dose of beta blockers. You sort of are afraid of increasing the dose of beta blockers because the heart rate is already low. So maybe you should stick to your mind that I am going to withdraw ivabradine if I am going to able to increase the beta blocker dose. Otherwise, it is something like a stalemate. You don't increase the dose of beta blocker subsequently.
But time and again, we have seen this. No, your patient at the time of discharge can't tolerate a beta blocker. You've given him ivabradine. Next visit comes back. Then at that point of time, you can introduce a beta blocker. So
but that doesn't usually happen. That is the problem.
Particularly in an acute scenario, I think.
Thank you, sir, for that excellent talk. You talked about the combination of isosorbide dinitrite with hydralazine. In India, currently, the status is that we use it mostly for reduced ejection fraction when the renal dysfunction precludes the use of the ARNIs or the ARPs or the ACE inhibitors. So, do you think that there will be an incremental role in adding this molecule in somebody who has not responded, even when the renal function is normal? We don't have much data, but...
yeah, that is the problem. Unfortunately, we don't have a data. Your guess is as good as mine. I don't know.
Would it be worthwhile looking at that? What do you think?
I'm sure. Now, I have one last comment. You focus so much on the American guidelines, and you even quoted the value statements. Do you believe the value statements have any applicability here or in Europe or anywhere?
That's very correct. The value is applicable to the society, depending on the socio-economic factors of that society. So I don't know whether it will be applicable here.
I would even say to the socio-economic status of the rich part of the society, because they're talking about 50 to 70,000 euro or dollars in that case per quality. I don't think any other society would subscribe to that. And
very correct. I perfectly agree. Very correct.
Shall we move on? Question from the floor? Please. Just speak up.
I want to ask this about the sinus tachycardia in young without heart failure or in just middle-aged. Can we use ivabradine? We are using beta blockers. And second question is LV non-compaction. Should we use this anticoagulation from the beginning, or should we wait for something to happen, or then?
I didn't get the second question. The first question, of course, there is no data. In sinus tachycardia without LV dysfunction, there is no data for ivabradine. Even in chronic stable disease, if there is no LV dysfunction, it reduces angina. That is all. There is no long-term benefit. Second question, I didn't get.
LV non-compaction, anticoagulation we should use or we should wait for?
I mean, in LV non-compaction, I would say that you should be more liberal in using anticoagulation, though there is no guideline that it is a class 1 indication. I think it is some sort of a off-label indication. But I perfectly agree that it is one situation where maybe you have to start oral anticoagulation.
And in elderly, this sometimes because with sick sinus syndrome, this ivabradine, should be careful because some patients we give on phone calls, we add ivabradine and then they get pacemakers after that.
No, sick sinus syndrome, if you say there is a sinus nodal abnormality, giving ivabradine may be dangerous. If it is only confined to the AV node, but that hardly ever happens. Usually it is a pan-nodal disease. So I think ivabradine will be dangerous in a sick sinus syndrome.
Thank you. Thank you so much. I think we are behind schedule, and thank you so much, Uni, for an excellent talk. So Dr. Manoj is not there. We call the third speaker, Dr. Arjit Kumar Ghosh. His talk will be on HREF versus MREF versus heart failure preserved ejection fraction, similarities and differences.
Good morning, everybody. I bring greetings from Armed Forces Medical Services. The picture depicts our Op Dosti, which we are currently in Turkey in the earthquake victims. Today, I am very thankful to the organizers that they have given me a chance to speak in this elite academic forum. The topic given to me is when heart failure with reduced ejection fraction versus heart failure with mid-range ejection fraction versus heart failure with preserved ejection fraction. The question is the similarities and differences. As you are all aware that the basis of heart failure is assessed by the LV function. So this topic is deliberated on this factor on which, on the various ranges of heart failure, on various ranges of LV function, we decide the various heart failure. I quote Braunwald, the incidence of heart failures is drastically increasing because of heart failure is the price we pay for the successful treatment of heart diseases. As you are aware, historically, the differences in LV function came to be noticed somewhere around 2013 in the European guideline, when we decided to divide them into reduced ejection fraction and preserved ejection fraction. Subsequently, it was noticed that most of the trials were directed showing benefit in the reduced ejection fraction. There was nothing which was catering for the mid-range ejection fraction, which became the middle child of heart failure. There are various terms which are used because of the confusion which has arisen because of this mid-range. It has been seen that in studies, sometimes 40% was included and sometimes 41 to 49% was included as ejection fraction. So subsequently, there were studies which got deviated. There were biases in study. We could not come to any conclusion. So now we have formalized that what is heart failure with reduced ejection fraction, that is less than or equal to 40, and what is heart failure in the mid-range, which is 41 to 49, and the ones which are preserved above 50. Most of the studies you can see were below 40 ejection fraction, which was done, and hence the need for this. But LV function is a very dynamic process, and patients transit between mid-range ejection fraction to preserve ejection fraction, and they decrease the LV function, they go to reduce ejection fraction. So it is very difficult to pinpoint a substrate of patients of mid-range ejection fraction because there are various independent factors and phenotype. Deterioration in conditions shift them from one category to the other. As per the 2022 ACCHA classification of heart failure, they have shown the initial classification and the serial assessment reclassification, which caters to some extent the problem which has arisen. When there is an improvement in ejection fraction, when there is a deterioration in ejection fraction, and when the ejection fraction remains the same. Now coming to the various factors which relate into the changeover from reduced ejection fraction to normal ejection fraction, majority of them transit, but near normal is rarely reached. Certain patients with certain diseases, when they have got preserved ejection fraction, deteriorate over time and come into mid-range. So our aim is to identify these patients who are going to improve and who are going to deteriorate. So there comes the need of having an registry analysis to find out what is the characteristics of these patients of mid-range ejection fraction whom we can identify and place them in the appropriate group. But there is a lot of fallacy, as everybody is aware, that we base an assessment based on LV function, which is not the true notion because it keeps on changing and there are various technical and various factors which come into play in assessment of LV function by the various operators. Another point to note is patient goes shift from one category to another. About 1/3 of them improve in function from reduced to mid-range and about 1/3 to preserved ejection fraction. The other way, there is a deterioration in function of 25% of patients in the reverse direction. So there is a very fluid situation in the mid-range ejection fraction. Based on this, there are various registries and trials, lots of data, thousands of patients. These data is just these 3 slides I'm just showing you the amount of data which is there about the demographics, the clinical condition, the comorbidities, lab factors, and the medications which are used in this subset of patients. My talk today is settled around how to summarize this full fact on what do we know and what is the similarities and behind the differences in them. To summarize in one single slide, observational studies and registries found that many clinical features are shared between all of them. Generally, heart failure in a mid-range resembles reduced ejection fraction in terms of etiology. Preserved ejection fraction, it resembles as far as comorbidities goes. There are multiple risk factors and comorbidities. They often coexist, although one pathophysiological mechanism may be more prominent in a single patient. This slide summarizes some of the key features: preserved ejection fraction, age, sex, the female sex, CAD is seen more in reduced ejection fraction, comorbidities, and the medications which are used. This is a slide which shows you the etiologies in patients of reduced ejection fraction and preserved ejection fraction. You see a significant amount of preserved ejection fraction are patients with hypertension. Significant amount of patients in the mid-range and the reduced ejection fractions are ISD and dilated cardiomyopathy patients. As far as the pathophysiology goes, there are major structural abnormality of heart failure with reduced ejection fraction is eccentric remodeling followed by progressive ventricular dilatation and volume overload, whereas in preserved ejection fraction, it is characterized by concentric modeling along with impaired myocardial relaxation and stiffness. Whereas heart failure with mid-range ejection fraction goes, it is a mixed bag of both. The biomarker profile is related to the stretch which is seen in these patients in reduced ejection fraction and inflammation which is seen in preserved ejection fraction. As far as biomarkers goes, in the mid-range ejection fraction, it is an intermediate zone between cardiac stretch and inflammation. An interesting study, epicardial adipose tissue volume was significantly higher in patients with heart failure in the mid-range and the preserved ejection fraction compared to healthy individuals, which can be a subject of study, which shows that metabolic and inflammatory mechanisms are involved. This slide summarizes, according to the shade, the characteristics which are predominant in the heart failure with reduced ejection fraction and which are in preserved ejection fraction. Point already stated, age, female, coronary artery disease, hypertension are the ones which are commonly linked at the two extremes of the disease. Now coming to acute heart failure, we have got very limited studies based on acute heart. Most of the studies are related to chronic heart failure. Here we see the distribution of reduced ejection fraction, preserved and mid-range are similar to them. What we see in the reduced ejection fraction, they are admitted in the congestive state in which they are more in shock, they require more inotropes. The mortality in patients with mid-range, low reduced ejection fraction is high. So what do we see? It confirms the findings of chronic heart failure. In the reduced ejection fraction, they have more hypotension and they need more inotropes. There is considerable hospital mortality. Post-discharge risk of heart failure, death and hospitalization is high. In the mid-range, they appear to be a milder form and preserved, had more comorbidities and greater non-cardiovascular risks. As far as the drug therapy goes among the three classes of heart failure, based on the ejection fraction, we have seen the guideline-directed therapy of 4 pillars have proven efficacious in reduced ejection fraction. In the mid-range and preserved ejection fraction, there are drugs in trial which are going to improve over time. As we see, as far the indication goes, in a congested state, they match the mid-range and the preserved ejection fraction. The drug therapy almost matches. 2A recommendation for SGLT2 and 2B for the rest of the drugs of the pillars of heart failure. A slide, a colorful slide, which shows us the similarities which are seen in patients with reduced ejection fraction and what are the features of preserved ejection fraction. What I've already highlighted, mortality is seen more in reduced ejection fraction, CAD, smoking, MACE and remodeling events, and cardiomyocyte injury, myocardial dysfunction, neurohormonal activation and increased cardiac troponin levels are seen in reduced ejection fraction. And it grades towards the preserved ejection fraction where it is seen more in women, older age, hypertension associated with other comorbidities. What is the outcome we've seen in across the spectrum of patients with heart failure? Among patients hospitalized with heart failure across the ejection fraction spectrum have a similar mortality pattern, survival with an elevated risk for cardiovascular and heart failure admission. These findings underscore the need to improve treatment of patients with heart failure. The survival rate was no different among patients among the 3 groups, but there are differences in outcomes across the ejection fraction spectrum have been observed in real-world studies and RCTs. So various studies show different results, but this is a 5-year analysis which has shown these findings. Now coming to the causes of prevalence of cardiac and non-cardiac causes of death. The patients with non-cardiac causes of death, we can see mostly are seen in patients with reduced ejection fraction and non-cardiac causes are seen in preserved ejection fraction. Now summarizing the prognosis, this is summarized, the same fact which I have said is being summarized in this slide. The color coding overlap shows that in the mid-range fraction it is seen. So the patient with mid-range ejection fraction, preserved ejection fraction and reduced ejection fraction are part of the same spectrum showing in the two extremes. What I wanted to highlight is evaluation of mid-range ejection fraction beyond LVF we need to do so that ejection fraction is subject to both biological and technical variability. Variables such as LV size, LVH, fibrosis, biomarker symptoms would provide more precise characterization of patients than ejection fraction alone. The heart failure mid-range population is heterogeneous mix, as I have already shown with the various data which is available. Designating somebody having heart failure based on ejection fractions tells us nothing about the etiology of the disease or mechanism involved. Comorbidities must be considered in characterizing patients with heart failure. Now this is a slide which shows in either axes the patient can move from mid-range, from preserved to reduced, and from reduced based on the various modalities and the characteristics. There are some knowledge gaps seen in the patient, and there are future directions which is entirely based on our data in which how we measure the patients with mid-range ejection fraction as per the echo basis and advanced modalities of investigation. Then there are pathophysiology which need to be addressed regarding risk factors, comorbidities, age and gender. Treatment strategies are evolving over a period of time for the various categories of heart failures. So with this, I end.
Thank you, Dr. Ghosh, for enlightening us on the various similarities and dissimilarities of the various types of heart failure. Now the question is, you mentioned that the mid-range ejection fraction it behaves like the preserved in terms of the comorbidities, and other way around in terms of the outcome, and the treatment is more like a reduced ejection fraction. Now when you talk about preserved ejection fraction, there are various phenotypes, and we all know that the phenotype 1, 2, and 3 will not be the same. So do you think it's possible to have a phenotypic marking for this mid-range ejection fraction? Does it make sense in terms of therapy?
So that is the recent advances where we have to go into precision tracking of these diagnoses, where what is the basis of the patient having a preserved ejection fraction, mid-range ejection fraction, what is the associated conditions associated with that patient, which decides the shift over from one category to the other.
And specifically, because it's not an easy entity to diagnose, preserved ejection fraction, the biomarkers may be normal, but what about mid-range ejection fraction? Are biomarkers helpful there?
There are newer imaging modalities which are coming into place. They are biomarkers based, which are trying to make a better understand better gaps in because there is a very fluid situation in the mid-range ejection fraction because the patient transits from one zone to another, and there are no markers which will define which patients will do, but more of precision medicine may help in this part of targeting which site of patients will do.
I'll give you a little hypothesis. And let's say you want to tell this a medical student has only 5 minutes for you because they have so many other things to learn. What if you tell them a patient with ejection fraction 45, just treat him like a HFrEF patient, give the 4 pillars of therapy and stop worrying. Is that a totally wrong message you would give the medical student, or is it the message is okay?
Can you repeat the question? The patient with the ejection fraction of 45% without any comorbidity, do you treat the patient as a patient of HFrEF, preserved ejection fraction? Preserved ejection fraction, when there is no associated past history of CAD on which he has improved over, there is no past history of heart failure, then this patient need not be unlikely to shift into the reduced ejection fraction group. This data does not exist. The patients who have been of ISD and CAD have shown an improvement in function. The cardiomyopathy have shown in which the therapy need not be withdrawn. The therapy should be continued. Otherwise, they go back to the original, or there are changes in the structure which will hamper and it will result in rehospitalization and repeat heart failure incidences.
What do you think?
I think the question is, will you treat them like a HFrEF, give them the 4 guideline-directed therapy and leave it just like that?
I tell you in the big trials, people are doing it. 80% they are doing it.
Even if we treat them with the same molecules, do we have to change the order of the therapies? would there be a difference? Yeah, on the floor.
I think it's working.
It's working, yeah. So in cardio-oncology, we use the ejection fraction, and we also have the usage of strain analysis. So if somebody is not going below 52%, we take help of LVGLS in a follow-up. So do you think in this gray shade of mildly reduced ejection fraction, in future, we will use this value, the LVGLS value, which has got the maximum reproducibility rather than the LV ejection fraction by biplane Simpson, to add anything to this?
As far as the studies which have aimed, in case LV ejection fraction, we are going into strain imaging, CMR as an alternative to find out there is an underlying thing. And there are better cardiac imaging softwares which are coming up, which can detect these patients who are actually have got the abnormality related to heart failure.
But guys,
strain imaging and GLS are...
I mean, you're talking strain, you're talking CMR. This is the 5% rich people medicine. 95% will not get this ever. I mean, in my medical school, oncology has 30 to 40 patients per day where they would need an ejection fraction because they start some sort of chemotherapy. How many slots do they get per day? 2. And we are talking about Germany and about a big medical school. This is dream medicine. I mean, I don't know. The cardio-oncology will come later.
Hello, excuse me.
One question.
With 45% ejection fraction, the person is without any comorbid condition and he is running his life without any complication, normal life. I think it is better to leave him as such without manipulating further.
Thank you. Dr. Mittal?
Yeah, one thing which I just want to ask you all is, where did the number 50, we are talking about 40% ejection fraction, where did the number 50 come from for defining preserved ejection fraction?
Life is about even numbers.
So I totally agree with you when you said if 45% was there, we would treat them on half-ref treatment. My side of the story is, let's go up to 50, even 55. Most of the trials, which have been negative trials, even if you look at Paragon, they showed that till 57, the results were positive. So I think this all is a gray zone. We have arbitrary guidelines, and I think in the future we'll clear them up.
Of course, when you, one second, if you quote, I will make a comment on your behalf. If you quote the ejection fraction interaction of Paragon, please also quote the sex interaction of Paragon. For women, sacubitril valsartan, you might easily argue, is a fantastic drug, just don't give it in men. Same argument as for ejection fraction.
Thank you so much. With the realization that we have more questions than answers in the mid-range ejection fraction, we go on to the next topic, the RED system for the assessment of lung fluid in heart failure. My pleasure in inviting Dr. Bhagirath Raghuraman.
Good morning, everybody. I'd like to thank Team Hfai and Dr. Abraham for giving me an opportunity in this forum. Many times when we admit patients with heart failure, the commonest question that they ask me at the time of discharge is, "Doctor, will this happen again?" Also, when we see patients in the outpatient department, the family is very worried. What are the chances of admission, and will they require recurrent admissions? Most importantly, the crux for all these questions is the finances involved. So there should be a sure-shot way to find out who is likely to get admitted, when to discharge the patient, and what we should do on follow-up. So REDS is one such attempt using technology to see how we can answer most of these questions. Basically, it is a military application. I think Ajit sir will endorse to this, that this was even used in the Turkey earthquake, that it is a technology that is to find survivors in the rubble when the buildings have collapsed. That is the foundation for this REDS technology. So technology is able to identify survivors in the rubble, uses a miniature radar system that employs low power electromagnetic signals emitted into the body. It is implemented in a wearable vest. Now, most of the population with heart failure are averse to invasive techniques. So this is one attempt to see non-invasively whether we can measure certain parameters that guide us in this endeavor. So it doesn't require contact with the skin and can be worn on top of clothing. Each sensor is a small rounded device capable of transmitting and receiving focused electromagnetic waves, and the beam is transferred through the pulmonary tissue. So essentially, you have a paddle in front, you have a paddle behind. It has a correction for the spine and also various levels. You also have a measuring tape to see what is the chest diameter. Based on this, once you place the equipment and place the recording, it takes 45 seconds from that time, and you get an interpretation in 90 seconds. So I think in 90 seconds, you're giving a fair idea to the patient and answer to most, if not all, of these questions. We know that heart failure is a problem of enormous magnitude in India. We have 8 million and counting. 1-year mortality is high readmission rates, expanding geriatric population. Essentially, each hospitalization gets the patient closer to the final event. So it is but natural that we should look at ways how we can prevent this entire sliding down. Most importantly, the cost involved. Most of us are aware that our patients are covered in a very limited manner by the insurance, if at all. Many insurance patients are not covered for these both OPD visits and only a partial amount for the hospitalization. So the average total expenditure as per current data is 1,33,663 per patient per admission. So that's an enormous amount, and add to this recurrent admissions, it's only going to make the patient poorer. Apart from this, there is readmission cost and out-of-pocket expenses involved. So this again becomes a big problem. Data for heart failure in India, I think this has been thrashed out in the last 2 days. Suffice to say that we have 1-year mortality statistics. The mortality rate is 30.8%, readmission rate is 30%. So if there is such a high mortality and such a high readmission, there must be a way in technology to find out how exactly to tackle this problem. Just looking into the basics of pulmonary edema, you have increased pressure or pooling, increased pulmonary venous pressure, which translates into increased capillary pressure, fluid in interstitial spaces, increased pressure in the interstitial spaces, and then fluid in the alveoli. So this is the sequence that all of us know happens in pulmonary edema. Now what if you are able to find out at the very first stage? Then definitely you can make a difference and you can prevent the onset of pulmonary edema, and this is where this technology steps in. We have a window of action. We have a timeline how we can intervene in this patient as he is progressing towards overt pulmonary edema or towards overt hospitalization. This graph here will show you that a good 35 days in advance, you will find that there is a building up of this pressure, and if you can catch it at that point, up the diuretics, up the aggression in terms of treatment, then you can avoid a subsequent hospitalization. So this is the road to heart failure hospitalization. You see that it passes through multiple stages, starting from a stable patient. You then find that there is a slow increase in the pressure and fluid changes. So at this point, if you initiate an increase in the diuretic dosage, which can be done even by a message or a telephone call to the patient, you can completely avoid the further cascade of events, which eventually graduate into autonomic adaptation, impedance changes, weight changes, and then finally hospitalization. So this technology should have the 5 A's. It should be appropriate, it should be accurate, absolute, actionable, and there should be an algorithm to interpret the results. So in the light of these 5 A recommendations, let's see how we can use the REDS technology. So this is the cartoon showing how the military uses it. In the mid segment, you're seeing how it is adapted to medical technology, and in the cartoon on the left side, you're seeing how it is just placed on the chest wall, and you're able to get data regarding the fluid in the lungs in 45 seconds, and you're able to give an actionable report in 90 seconds flat. This is an animation to show how this is used. You place it on the chest wall, and this is the technology. Within 45 seconds, you're getting, this is the measurement in progress. You're seeing it in the lung fields, how the fluid levels are being measured. This is the anterior and posterior segments. This cartoon I just showed you how the progression happens, and at each of these stages you're getting a good result and you can take action accordingly. So this is overall, it's a miniature system. You have 45 seconds to get the data and 90 seconds with the report, and then you can talk to your patient. If the patient is having a home visit, your medical social worker or your nursing staff is in the patient's house, you can talk to the patient on the phone and convey to them what is the change in dosage that you recommend so that a hospitalization can be prevented. It's accurate, it's validated, FDA approved in current times. The power that it uses is very, very small, 1/1000 of what your cell phone uses. So it's really cost effective to that effect. It's easy to use. It can be put on top of clothing, so you don't have the need to go invasive, and also you have a reading in just 45 seconds. So where it can be used, what are the situations? It can be used in the emergency department. Many times you have patients with profound breathlessness. So is there fluid or not? You can add, apart from your clinical acumen and also the measurement parameters that are available to you, you can use REDS to find out whether there is pulmonary edema and the patient requires admission. Also, you have certain cutoff values. I'm just coming to that. Based on that, you can decide the intensity with which you need to be aggressive in terms of treatment, and I'll just elaborate that in the next slide. Also, pre-discharge, is your patient fit for discharge or still fluid is there? Because if still fluid is there, then there's a likelihood of admission or a readmission that can happen in the next few days. In your outpatient clinic, you can use this to judge the efficacy of your treatment. For home care, you needn't visit each and every patient, and many patients in the Indian scenario find it difficult to come to the hospital for a visit. So your medical social worker or your nurse practitioner can operate this and convey to you the results. And of course, at a primary care level. So in the hospital, it can be used in the heart failure flow, in your heart failure department, emergency department. At hospital discharge, this should be one of the checklist in your hospital. In the outpatient clinic, it can be used regularly, and of course, in a skilled nursing facility where you need not have to be present at all times. There are some contraindications to REDS. So the notable ones are if there is a large pleural effusion. Mind you, the REDS technology can be used on the right lung because in the left you have the heart coming in, so the right is where the REDS, the transducer is placed. But if there's a large right side pleural effusion, then again the values are likely to be erroneous. Pneumonias requiring antibiotics, acute decompensated chronic kidney disease. Apart from this, there's a caution in certain areas. If you have an extremely well-built bodybuilder, huge muscle mass, again, there the values are likely to be erroneous. If you have a very, very large individual with a large BMI, let's say 35 BMI, there also the values are likely to be erroneous. And further, in a chronic obstructive airways disease where there is air pooling in the lungs. So these are certain caution areas, but suffice to say that for the vast majority of the population, it can be extrapolated to give meaningful results. Pre-discharge REDS. Pre-discharge ensures that the patients are adequately decongested. I'll just show you a study coming up wherein we could find out who really needs the admission and at what times prior to discharge, so that there is a reduction in the risk of hospitalization. Now, this is the algorithm that I was speaking to you. The safe value is 25 to 35. So based on REDS, what all interpretation you can give. If you have a value below 21, this means that your patient is extremely dehydrated. You've given him a huge dose of diuretics and the patient is dehydrated. You actually have to give him fluids. If you have a value of 21 to 24, it's low normal. You consider to reduce or discontinue the diuretics. If you have 25 to 35 value, then it means it's an optimal volume status. If you have 31 to, let's say, 40, it's hypervolemia. You have to up the dose of diuretics. Over 41, intravenous diuretics, and above 50, you have to advise the patient hospitalization. Now, this is the 25 to 35 safe limit. Compares well with the CT. If you have a REDS score of 34, the pulmonary wedge pressure is 18 millimeters of mercury. The accuracy is 94.9%. So you can define who needs to be hospitalized, who goes home, and also indicates who needs more fluids. Correlates well with the pulmonary artery pressure. I just told you, you can accurately tell when the REDS value is more than 35 that the wedge pressure is more than 18. You also have a St. Barnabas study. they used what we call a REDS guided diuretic protocol, which says that the readmission rates can be reduced to half. And this is the best HF RCT, which says that patients at the time of discharge, you have to do this REDS so that you know who is adequately decongested and fit enough to go home, else retain them for a few more days of diuretics. Mount Sinai has got a REDS protocol. I just elaborated just now. Suffice to say, the other ends of the spectrum are less than 20, hold the diuretics or give fluids, and more than 46, advise intravenous therapy or hospitalization. Emergency department to see who needs admission for which reason, and definitely whether there's acute pulmonary edema. This is the ESC guidelines endorsing how you can non-invasively measure the fluid in the lungs. It's a class 1 indication, and these are the competitors for REDS, what we have: bioimpedance monitors, daily weight measuring, and so on. Suffice to say that REDS is in a big way superior to these and gives us more accurate values. My last slide. REDS can be easily used by physicians, nurse practitioners, community health workers, and even by patients themselves. We have certain educated patients who can put it on themselves with the help of their caregiver and give you accurate results. Phone in your physician and tell them that this is the value and adjust the diuretics. Who needs REDS? Patients who have heart failure in the hospital, fluid management at home, taking diuretics at home, those living with heart failure, and also recovering from a coronary artery disease event. Can be used in hospitals, OPD clinics. I just elaborated all this. Just REDS your patient. Thank you very much.
Are you using the technology in your place already?
We had a demonstration available. The team is in negotiation with our hospital regarding the costs. They have 2 ways in which we can use this. We can pay upfront for the equipment. We own it, and then we can price it according to the hospital management. The second way is we take it on a rental basis and pay a slightly higher amount. So at current times in our hospital, the second option seems to be more viable, and our management is in talks with the REDS group.
But what is the cost, approximate cost the patient?
It's about 12 to 14 lakh rupees if you're buying it one time, and per patient is 250 rupees.
250 rupees.
Yes,
That's for
I
the
think
hospital.
it's
for
a
the
small
hospital
amount.
visit. For the hospital visit.
250 to the patient.
No, during the hospital
we can waive it off. 250 is, it's okay. You can
Thank you.
avoid
I
the
think,
hospitalization.
We are actually in our place now using it because the colleague was about cardio-oncology, because actually we don't have enough cardiology services. We are now trying to use this in palliative care and cancer, where there's lots of congestion, but I quite like it. But of course, the cost situation needs to be assessed in each place. For us, it's a clinical research tool of first quality, but I guess in the future we want such things. But what do you think?
I think so. I think it's really a way forward, and because we have the invasive devices which helps you with OptiVol and things like that. So I think
CardioMEMS is 25 lakh rupees, whereas this is 12 lakh rupees and can be used for many patients. CardioMEMS is only for one patient, and that's invasive.
Thank you.
I
Thank you,
also
Dr.
have
Bhagir.
an invasive, I have an industrial house who's agreed to sponsor it also, so likely to get it in the next 1 month.
Thank you, Dr. Bhagir. Thanks for an excellent talk. For shortage of time, I think we need to go to the next speaker, Dr. Sanjay Mittal, managing the patient with worsening heart failure with Versiguat.
And of course, you realize in 5 minutes the session is finished.
Very good. Thank you. Good morning to you all. I would not waste time here, but let me start with a case. This SS 60 years old gentleman, diabetic hypertensive, cardiomyopathy, presented with ejection fraction of 30% and moderate MR. And CRTD was done in 2014, and what was happening is that in April of 22, NT-proBNP was 1600, and the person was put on all guideline-directed medical therapy. One of the 25% of people who would be on 200 milligrams of metoprolol succinate, 200 milligrams twice a day of Arnis, dapagliflozin 10, spironolactone, and torsemide. His iron saturation was low. At that time, in April, the ivabradine and FCM was given. But what happened in August 2022, he has worsening of dyspnea, NYHA class 3, required escalation of diuretics, BP was okay, pulse rate was 78, and on top of this, the question was, is this worsening heart failure? Why should we at all bother? And can we have some options for this person? Well, worsening heart failure is an important event, and it's still evolving. And evolution is such that the guideline definitions are also changing. If you look at the European Society of Cardiology guideline update in 2021, it just mentions for the first time worsening heart failure and had unfortunately no definition. In ACC guideline 22, it was for the first time defined as worsening sign and symptoms of heart failure along with worsening functional capacity, but that was it all. But most of the trials which have used worsening heart failure as enrollment criterion, they include hospitalization for heart failure reasons, emergency department visits requiring IV diuretics, or unscheduled OPD visits requiring IV diuretics as inclusion criteria. Why should we at all bother? Well, because of the fact that after a lull period, if you look at this lull period when you have stabilization of the heart failure period, the symptoms and the mortality and morbidity is minimum. But once these readmissions for heart failure start, the mortality and the morbidity suddenly increases, and it is going to be eminently going towards the stage D heart failure, where devices and nothing works and VAD and transplant is going to be required. So these are actually periods where people have to indicate that this person is worsening and has worse outcomes. And this data is very clear. This is on the basis of 5,600 patients' data in hospital patients who were discharged. If the person is in chronic heart failure, it has about 5.9% morbidity rate in 1 year's time. But worsening heart failure admission, hospitalization requires about 27.7% event rate, mortality rate at the end of 1 year. So that is almost 4 times the normal chronic heart failure rate, and even worse than the de novo heart failure admission. The other thing which I wanted to mention here is that if you have heart failure hospitalization, which is a representation of worsening heart failure, it increases the risk of CV death by 46%. And not only that, let's talk about people who have requirement of injectable diuretics, not only hospitalization. It is seen that 56% in one of these US registries, over half of the patients were rehospitalized within 30 days. So it is a big problem, rehospitalization. But let's talk about the outdoor escalation of diuretic therapy. If you look at the Paradigm HF sub-analyses as well as DEPA HF sub-analyses, whether it was OPD escalation, emergency department visits, or hospitalization, everything was much higher risk as compared to those who never required that. And even DEPA HF, although the OPD escalation of diuretic therapy was less as compared to the ED or hospitalization, but still was more than the people who did not require hospitalization or escalation of diuretic therapy. So this is a worse event. And what happens is, we have to understand, despite the 4 pillars, nearly 14 to 15% of people would require escalation of therapy. Well, what do we have? I'm going to talk about this new target, the novel target for heart failure reduction in ejection fraction. Well, when we have heart failure because of the inflammation and decrease in reactive oxygen species, the nitric oxide pathway is also disrupted, which in way leads to ventricular dysfunction and vascular dysfunction, and this is responsible for worsening of heart failure progression. And what can happen is by the soluble guanylate cyclase inhibitors, vericiguat in that matter, what can happen is it can potentiate the nitric oxide in cellular to increase the soluble guanylate cyclase activity to promote CGMP production. And also directly vericiguat attaches to the SCG to actually increase the CGMP. So both ways it can increase the soluble guanylate cyclase, which leads to first inflammation and fibrosis decrease in myocardium. It causes decrease in inflammatory vasculitis and increased vasodilatation, and also decrease kidney fibrosis and increase renal blood flow, which all is important for heart failure progression improvement. On the basis of the Victoria trial, which is the salient features were 5,000 patients were enrolled, more than 5,000, and the worst patient of them all, because the average NT-proBNP was 2,800, which was maximum from those contemporary trials. And almost 41% of people in this particular trial were NYT class 3 or 4. And also what is important is nearly 84% people were actually hospitalized within 6 months of the enrollment, 16% within 3 months, and 11% were taken while they were in the hospital. The eGFR was 15 ml per minute per 1.73 meters square, and the standard of care was pretty good. 93% beta blockers, MRAs, and almost RNAs and other things, including 88% people. So very good treatment. And the worst part of this thing was almost 38% events per 100 patient year was expected in this particular population. Almost 2 to 3 times higher than the contemporary patients. And despite that, there was almost on an absolute risk reduction of about 4.2 in the terms of hospitalization for heart failure or death within the span of median 10.8 months, less than 1 year. And this is something which is important. More than that, almost 90% of people reached to the dose of 10 milligrams per day. And also it was seen that there was no statistical significant difference in hypertension or the people requiring stoppage of drugs for hypertension. NT-proBNP reduction was also significantly different between the two components of placebo versus vericiguat at the end of this trial. And more important than that, the vericiguat may mitigate the need for additional heart failure therapies. This is something which is important, that people who actually were taking ARNIs, in those people also the benefit was there. It was safe. Let me go to the important message, the last message I am going to transfer to you. Well, worsening heart failure, which is the candidate for considering vericiguat? We know it's class 2B indication according to the various guidelines. But worsening heart failure, as we defined, is people who have worsening symptoms, requiring hospitalization for heart failure, emergency visits, unscheduled OPD visits requiring IV escalation, IV diuretics, or escalation of oral diuretics or restarting of the oral diuretics. All of these things are defined worsening heart failure events. But there are certain more things which are up in the pipeline. What about people who have increase in NT-proBNP on the follow-up more than 30%? What about people who have increase in troponin I despite no ischemic heart disease? What about people who have, just like Dr. Bhagirath was mentioning, the CardioMEMS or RIDS device showing pulmonary congestion? And what about people who have worsening quality of life care? So those are probably in future going to be guideline-directed therapies for worsening heart failure diagnosis. So if the person is admitted with worsening heart failure, has all the guideline-directed medical therapies, as my case was, a case directly for vericiguat. Those who are not in optimal dose of the 4 pillars, well, we can increase them, but also add vericiguat at the same time, because this is still in the definition of Victoria trial. And those who are not on the guideline medical therapy, the first thing was to add them, and maybe in subsequent hospital visit, consider about vericiguat, because this is still a bad prognostic sign. Start them after we have stopped IV diuretics, and eGFR is okay. And the only other thing which I want to mention is start with 2.5, escalate after 2 weeks to 5, and then to 10 milligrams per hour. The time is up, and so is my slide. So the only thing is important is be cautious. Nitrates and the PG phosphodiesterase inhibitors 5 should not be there, because they can cause precipitous hypotension. So ladies and gentlemen, we have this course. Worsening heart failure is a bad event, and this can be addressed by considering vericiguat in this particular follow-up. The earlier we act at outdoor level, the better the long-term outcome is going to be. If act too late, it's going to be worse. So that is a point to be considered. Thank you.
Just one question. Does it equally act on DCM, idiopathic DCM, as well as ischemic cardiomyopathy? Or
I can't hear you properly. Sorry.
Yeah. Yeah, does it have equal action on ischemic cardiomyopathy as well as idiopathic cardiomyopathy, or has to be used only in?
It is not defined. It is both the cases.
Both the cases.
Dr. Mittal, it's a good drug. In fact, I have tried it on many patients, and we were discussing, is it through the cyclic AMP and the nitrous oxide release and all that? So the nitrate, is there a tolerance? Is that the reason why you have to escalate from 2.5 to 10?
Yes, because this is the first trial we have, and the only way to know the experience. And you remember, we are all in guideline-directed medical therapy. The guidelines determine, and the guidelines are based on the experiences. It's safe. There was no major blood pressure fall, and 90% of people could be escalated to 10 milligrams per day, but the guidelines say 2.5 milligrams to begin with. If the blood pressure is extraordinarily high, then you can even start with 5 milligrams, because it's the blood pressure. And we know heart failure with reduced ejection fraction, especially those worst patients who are getting readmitted for heart failure, may have a borderline blood pressure. So start with 2.5 and then escalate.
No, why I'm asking you this question, I have seen this in 2.5, the patient makes a remarkable improvement initially. But then down the line, even if you start looking at the echo, it's not, the efficacy comes down. Maybe that's the time when you start escalating into higher levels. So the question is about tolerance. Professor Stephen Anker?
Well, for me, this is a really possibly very important addition to our drugs, and maybe the best candidate as a fifth pillar if the Victor trial works out, with the one caveat: yes, we give it in worsening heart failure, but not if it's too bad.
Yeah.
Kind of the anti-BNP above 5,000, 6,000, there's the threshold, don't do. But below, fine.
No, even in 8,000, there were not mortality benefits. Probably the ventricles were too far gone at that level, as you rightly said, and nothing can be done in that scenario. So one is to prevent the people reaching to that 8,000 level and then act. So that's what my side of the story would be.
I really would caution against the use of 8,000. It's a post hoc number.
Exactly.
The pre-specified number is the highest quartile, which is 5,300. This is one of the mistakes, I believe, of the whole communication about this drug, trying to push 8,000 when it's actually 5,300. That has turned off a few people. And the communication would be so much easier. Just wait one day until it's from 8,000 to 5,300. It's one day.
Yeah.
Finish this session. I think it was a very exciting session. Thank you, Dr. Mittal.
Thank you.
And I don't know whether we immediately go to the even further exciting session.
Thank you, moderators and the panel members, for sticking on to the time and enlightening us on GDMT. Moving on to our next session of 9th Annual Conference of Heart Failure Association, may I take an opportunity to welcome Dr. V.K. Chopra and Dr. John Terling to chair the session.
Can we have Dr. Tierling also on the screen?
I'm not that good looking, it's okay.
General announcement for the delegates. Delegates are requested to keep their mobile phones on silent mode during the session.
Has he joined?
Yes. I've been here.
Hello, John. Welcome.
DJ, I'm here. I've been here for the last
You're muted.
multiple talks. Nope, I'm not muted.
You're muted.
I am not. It's you.
So, welcome, ladies and gentlemen. Great pleasure to have Dr. John Tierling, President of Heart Failure Society of America, as a co-chair. And it's a great pleasure to welcome Dr. Stephen Anker, who's been a long-standing friend of Heart Failure Association of India right from its birth. And I think single-handedly he has pushed us into a closer cooperation with Heart Failure Association of ESC. He's been with us in each one of our conferences and very frequent visitor to India, and we love listening to him. He's also pioneered several path-breaking trials and therapies in heart failure, most notable recent ones being the extensive use of IV iron, which I think he has pushed very successfully, and that has benefited our patients, and more recently, the use of SGLT2 inhibitors. So, Stephen, a very warm welcome to you, and we look forward to hearing your first talk, which is going to be redefining and unifying management of heart failure across the spectrum, learning from Emperor study programs and recent updates. Stephen.
Thank you so much. And the first thing I have to do is I have to apologize because now I'm going to redefine India Standard Time, because I was told actually that my talks both should be 15 minutes in duration, not 10 plus 5. Now it's highly embarrassing, of course. We need to do a vote. Do you want me to give a 15-minute or a 10-minute talk? I can do the same number of slides faster if you want.
15.
All right. So basically, I'm sorry really about this. Let me just say SGLT2 inhibitors really are a big success story of the last, I would say, almost like 8 or 9 years in medicine in general, and of course of the last 4 years in cardiology. And all these trials highlighted here in yellow, they are positive trials. And when have you seen something like this recently? There will be more trials coming in the post-MI scenario, and it shall be interesting to see what happens. In order to save time in this talk, I will not talk about all the details of the trials. Emperor-reduced, DAPA-HF, very positive trials, very fast benefits, and you can see both trials, 25% reduction in cardiovascular mortality and heart failure hospitalization, and then giving these kind of meta-analysis results showing a great similarity overall for the cardiovascular mortality results as one component of the very similar primary endpoints. And then, of course, the same similarity, even more so for the combined endpoint. Very, very powerful results. Now, what was exciting for the whole field of medicine was that these anti-diabetic drugs became drugs for cardiorenal metabolic patients in general. In other words, also being significantly beneficial in patients without diabetes, which is highlighted here. Yes, they work in diabetic patients, but they also work in non-diabetic patients. There was one question, however, when people saw us designing the trials, asking whether or not the inclusion of patients with pre-diabetes in the non-diabetic patients is kind of cheating or not in terms of doing your trial design. Well, you can see here patients without it and with diabetes have very different event rates. And if I show you now, in addition, the distinction where this group is split in two groups, the patients with pre-diabetes and the patient with no glycemic disorder, you can really appreciate that the patients without diabetes, including the patients with pre-diabetes, is the correct thing to do. And this is a great piece of knowledge, I believe, coming out of these trials as well. You can see the Kaplan-Meier curves here for the combined endpoint being very similar. And you can see this also, and by the way, you can see exactly the same data with dapagliflozin from the DAPA-HF trial, with and without diabetes. First and recurrent heart failure hospitalizations are reduced. Very effective drugs in HFrEF, and that's why they are already in the guidelines. Now, in preserved ejection fraction heart failure, we have two trials, again positive, but these trials came a little bit too late for the recent guidelines. And so Emperor, Preserved, and now also Deliver tell us what to do for these patients, and I believe we can expect some good recommendations coming out of the next guideline updates very soon also in Europe. And then, of course, with two trials being successful, you can expect what you probably can expect from this with a Class 1A recommendation. Now, what was the result in Emperor Preserved? You, of course, notice a 21% reduction, and importantly, also like in HFrEF, very fast benefits, which of course leads us to speculate about mechanisms of action here. Is it really the kind of nutrition, kind of prevention, fasting, metabolism kind of induction, or is it really an anticongestive effect to some degree? It's probably a little bit of both. Also for heart failure patients with a preserved ejection fraction, you can see this data that it works in patients with and without diabetes again. But also you can say, and this is now the big difference to what we discussed before about the Paragon trial, no sex interaction, no interaction for the kidney function degree that these patients have being impaired or not. And you can also see that for prior treatment with an MRA, prior treatment with a RASI therapy, not much of a difference. Now, in this short talk, I don't want to belabor it too much. There is no ejection fraction attenuation of benefits. This is the primary pre-specified ejection fraction analysis for the primary endpoint, which probably, if you consider subgroups, is the subgroup to consider in this context. Please note this trend test p-value 0.21, showing that there is not much of any difference. Despite visual impressions, there is no difference in the results. And if you take overall now what we see here in heart failure with the preserved ejection fraction, the combined endpoint of cardiovascular death and heart failure hospitalization is reduced. This is driven by the recurrent heart failure hospitalizations. There is a modest, small, non-significant effect in the cardiovascular mortality direction. I come back to this in a second. We also see some benefit with regards to kidney function over time. That did, however, not translate into heart kidney outcomes being reduced. Now, what we typically also see in these trials of chronic stable patient, and please note in unstable patient, the results look very much different with a 3 to 4 times better quality of life average result. You see about 1.5 points difference in the Kansas City cardiomyopathy questionnaire, which basically means every 10th patient gets a meaningful change in quality of life. These average results are also, of course, hampered by the fact that many patients at the time of the visits, they are in hospital, not available. So really we have only the visits when we are doing it. Now, all of this is done in a preserved ejection fraction trial that started with ejection fractions of 41. This was designed when we didn't have the HFmrEF kind of category yet, but basically it means these are trials, deliver as well as Emperor preserved, of HFmrEF and HFpEF patients together. So what you want to see is the true HFpEF result, and because that is important, we were actually able to manage that last year in December. This was published in Nature Medicine as a subgroup analysis because it's really a meaningful and important subgroup, and it's a big subgroup of 4,000 patients, 73 years of age, and all of them having 50% and higher ejection fraction. Half of them women, diabetes, half of them AF, half of them, you can see here the average natriuretic peptide is 950. And look at the treatment. We discussed about HFpEF, HFmrEF therapy. This is the reality of people voting by their feet. In other words, physicians already treating the patients we have in a way as if they have HFrEF, despite having HFpEF. Of course, the reason is not only because they believe all people should receive heart failure therapies, but because also there is comorbidities like hypertension, very frequent in these patients. But 80% RASI, 84% beta blockers, 1/3 MRAs. And in these patients, you have here's the primary endpoint for the patient with 50% and higher ejection fraction. Here's the first hospitalization for heart failure, and you get significant positive results. These results are here shown in the Kaplan-Meier, also early splitting of the curves. So very similar results for the patients with the highest ejection fraction. And if you take all the results together now, for SGLT2 inhibition, in this case empagliflozin, below 40, mid-range, and also true HFpEF across the spectrum of ejection fraction, this works. And if you compare the results, you can see here, given for Emperor preserved versus all the other prior trial programs, first of all, a convincing amount of benefit with a relative risk reduction that is meaningful, 21%, and a convincing statistical results really with a very significant p-value, 0.003. And most importantly, and this is for science very important, validated in a second study. The DELIVER trial has validated this. Here are the two primary endpoints, and very few people really pay attention to this. For the full population, for the patients with ejection fraction below 60%, 18 and 17% relative benefit. very similar results as in Emperor Preserved. If you take here a like-for-like comparison, taking the definition of events in Deliver, you can of course do it also the other way around and take the definitions as used in Emperor, but basically here the definitions for the Deliver, and you can see an 18 and a 24% benefit, very much overlapping. And when you do a formal, but this is a published data meta-analysis of all of this, and this was published in the Lancet last year, no difference whatsoever for any of these important endpoints. These are the interaction p-values between Deliver and Emperor Preserved, no difference whatsoever. So really, when you see these results, what remains to be done is you need to implement what probably is in the future guidelines to give this therapy. But then the next question starts, well, where do you start to give these therapies? And can you start them in the hospital? That's the question. For the transition phase from the worsening heart failure situation we just discussed to the outpatient stable phase. And basically in this transition phase, we believe SGLT2 inhibitors can be given. For empagliflozin, we now have the data. For dapagliflozin, we still will get them. Here is the EMPULSE trial results. The trial was a trial of 10 milligram once daily versus placebo, and it had an innovative new endpoint of overall clinical benefit. That means you analyze death, the number of heart failure events, the time to the first heart failure event, and the change in the Kansas City Cardiomyopathy Questionnaire for Quality of Life. So a win ratio, if I explain very quickly, means a very efficient way of comparing all patients from the one group with all patients from the other. If you have 100 and 100 patients, that means you have 10,000 direct comparisons. Now you look for the wins, depending on these criteria here. When you die first, then you have lost and the other person has won, etc., etc. So you analyze the wins, the losses, and the draws. The draws you ignore and you just calculate the win ratio, the win over losing ratio. And because you do this 10,000 times, you can have a confidence interval, you can have a p-value, and this was done in these patients with and without HFpEF. 1/3 about had an ejection fraction of above 40% in this population of hospitalized and immediately after hospitalization discharged patients. And the overall benefit was significantly positive. A win ratio, just to give you an idea, in a trial of 500 plus patients, any win ratio of about 1.2 to 1.25, so 20 to 25% clinical benefit gives you a significant result. 35% benefit is big, 50% benefit in a win ratio is huge. Now, here you can see the win ratio 1.36, highly significant. This is the overall benefit, but here you see time to death, already 7.2 versus 4% wins. So that means it goes in the right direction also for things that are not quality of life driven. Quality of life is the biggest thing, but also for heart failure, hospitalization, and death. And if you look into the quality of life specifically, here you see what I said before, the big benefit. If you have unstable, sick patient, you get from SGLT2 inhibition a very big effect, but you also get the benefit on the events for these patients. Here you can see not pre-specified, I have to say, all-cause mortality and heart failure hospitalization with a 35% reduction. So with all of this data now shown to you, you know that HFrEF, it is already in the guideline to give SGLT2 inhibitors with a 1A indication, very clearly besides all these other things. Well, what will happen in HFmrEF and HFpEF we shall see, but my prediction is a 1A indication. Thank you so much for your attention.
Can we have Dr. Tierling on screen, please? So, Stefan, thank you for that excellent overview, as usual. Any questions from any quick questions from the audience?
Please.
So you said we all are expecting it to become class 1 indication.
In HFpEF.
In HFpEF.
And HFmrEF, I guess.
Yeah. But the only unfortunate thing is that till the mortality benefit is there, it's going to be very difficult to push it into class 1. I mean, your comment on this.
Well, basically, if you take the liver trial and the Emperor Preserve trial together, you have a 12% benefit on cardiovascular mortality. In the published data, summary data meta-analysis, the p-value was 0.052. If you believe in p-values, depends on what you make out of this. I can promise you, if and when there is a published individual patient meta-analysis, the same result would become clearly significant. If you add the preserved ejection fraction heart failure patients from the sotagliflozin studies, it will become clearly significant. I strongly think there is a reasonable, modest 12% or so benefit on cardiovascular mortality. But really, we have not done the trials to specifically show a cardiovascular mortality benefit alone. We have done the trials for the combined endpoint. I think the consensus in the heart failure community is that both these things together matter. And let's not forget, the trials were only like 2 years long. The heart kidney outcomes that I told you were not significantly reduced. You see this after 3 or 4 years. I have no doubt that such strong reductions in heart failure hospitalizations would lead into later cardiovascular death benefits. But of course, we will probably never be able to show this prospectively.
John, your comment? Just
one quick comment. So, Stefan, I think it's remarkable that once again, none of our heart failure drugs were actually originally developed for heart failure. So that's my one comment. And I think it's just remarkable. And the second thing is, and this should be short, but do you think there's going to be a difference between SGLT2 inhibitors and the combined SGLT2 1 and 2 inhibitors? Do you think there's a difference? And if so, is that going to be meaningful?
Well, you know and I know that, of course, unfortunately, the soloist studies were stopped too early and don't have the power we were all hoping for it, with more than 4,000 HFrEF patients and 900 HFpEF patients. In the end, it was more like 1,200 patients in total, so almost like a quarter only recruited. That gives limited kind of power to any such discussion. We know, of course, there is a trend for reductions in non-fatal stroke and MI, more with SGLT1 inhibitor drugs containing this inhibition function than SGLT2 inhibitors. I would say, if I had to bet, I would say they probably are similar. If I don't have to bet, I would say let's do some more trials with this.
Thank you. Very, very brief.
Well done.
Very brief comment. One quick comment on this. Worsening heart failure or hospitalization for heart failure is a surrogate marker for future mortality. So is there any effort to redefine the definition of mortality outcomes in the guidelines?
No, I don't think so. After all, you probably are only dead when you're dead. The one problem, of course, is with cause-specific mortality versus all-cause mortality. So are we only shifting the way we are dying? Let's not forget this was also true in part when we compared in the past low-dose statins versus high-dose statins in the TNT trial, where of course we had dramatic reduction in cardiovascular mortality, but all-cause mortality had a hazard ratio of 1.01. This is something we as a society need to decide whether we accept that cause-specific event rates are acceptable for us to pay for things and to prescribe things. I think at this moment there is a strong consensus for this, but I can easily see also pushing for all-cause mortality in the near future. But then, of course, somebody has to develop more powerful therapies to achieve exactly that.
Last very brief comment to the...
Yeah, Stefan, thank you for this lecture. From these two clinical trials, what protection you would expect against a new onset atrial fibrillation with SGLT2 inhibition?
Modest to none. And really the trials are absolutely unable to answer this question. And atrial fibrillation, and I will make in my next comment a few small comments about this, is notoriously difficult to define and assess reliably. We would have to have really a long-term assessment of rhythm in these patients and not just spontaneous ECGs. And in our trials here, it was even non-systematic collection of data and extrapolating kind of some findings in adverse event reports as a possible sudden death prevention. I would be very careful. I don't think that they have, at this moment, any good evidence for atrial fibrillation or sudden death prevention capacity.
Thank you. John, you want to introduce the next topic?
No.
So I'm sorry, I was on mute. So Stefan, we have the opportunity to hear about how advanced cancer is a cardiovascular disease, which I have a feeling I know where we're going, and I'm looking forward to the journey. So Professor Anker, please take us on this journey in terms of why advanced cancer is a cardiovascular disease.
Now, I shall start with declaring some odd ways of conflicts of interest.
Yes.
First of all, family of ours died exactly in the ways that I'm describing, and this is making all of this personal. Second of all, in the last 5 years, my research department's actual work is all in this. And some of these ideas, and this is the last conflict, are more than 20 years old. And then you will see some of the things we have not published for more than 10 years. That's why some of the studies you will see have 80% mortality rates. To me, this is highly exciting and very actionable. The event rates you will see are higher than in consensus, and this is cool. Now, when I talk about cardio-oncology, I do not talk about chemotherapy-induced toxicity. This is an important field, but it's actually fairly straightforward in many ways, if only you have the resources to manage it in a straightforward way, do the assessments of cardiac function in one way or the other, and make the appropriate conclusion for your therapy. This is not really intellectually challenging, so that's not me. We do other things. Now, let me start with a provocation. This is Claude L'Enfant. He was the NIH president and basically National Heart and Lung Institute president, and basically he had a very famous editorial in the New England Journal about lifetime gained from different research clinical medicine areas, and cardiovascular medicine really was leading, and you can see all the other fields, notably also cancer, very much behind. And now this was the conclusion that basically politicians took from this. We live longer due to better management of cardiovascular disease. Now let's fund other works. Totally wrong conclusion. The logical conclusion is this: all diseases should be treated by cardiologists. And I do not mean this as a joke only. This is a wake-up call. And I actually mean this because in the end you die and your heart stops, so maybe there's something about the heart and all these other diseases. Now, is there some data to support these kind of ideas? Well, first of all, here you see symptoms of cancer patients. Okay, pain, easy fatigue, weakness. Sounds a bit like heart failure to part. Dyspnea gets quite interesting, quite a lot actually. Weight loss, that's cachexia. Edema, at least a quarter of these patients. And we are just about to analyze and submit into a cardiac journal the number of basically lung punctures to get rid of pleural effusion. People have never really considered the amount of interventions done to these patients. But if you look, for instance, on the side, here cardiovascular death, about a quarter of all cancer patients are thought to have cardiac death. Trust me, very unreliable data. This is small numbers, retrospective, no prospective assessment of cause of death in any cancer trial ongoing. So then, in 2014, Stefan von Heling with some of his people published a little comparison about healthy controls
colorectal cancer patients versus heart failure. Ejection fraction, you can see here almost 60% on average. Essentially nobody, maybe one patient below 50%. For our internal use, we say we want definitely non-heart failure patient ejection fraction 50% and higher. And you can see here maybe a significant reduction, but nothing like in heart failure. But the peak VO2, the exercise capacity of these patients is already impaired. Okay, one thing. Then splitting the patients into chemotherapy naive and non-naive patients, and we found a heart failure-like syndrome is already present in treatment naive colorectal cancer patients. Not only reduced exercise capacity, but poor heart rate variability and really confirmed neurohormonal activation. Of course, this is the not classical way of looking at heart failure, but more like the neurohormonal activation side of things. So how could this all fit together? These are all the problems you have in cancer, let's say the challenges to the heart, if you like. And yes, they include the anti-cancer therapies, but there's also oncometabolite, there's oxidative stress, there's inflammatory cytokines, whatever. And that's all the things you can get from this. Cell apoptosis, fibrosis, very important. This is a big thing we now do. But then also cardiac wasting and arrhythmias, and I would like to focus on these two things. The most simple form of what I would call a relevant arrhythmia is simply having high heart rate. And high heart rate here, you can see a prospective study. If you have above the median heart rate in this cohort of patients, colorectal, lung, and pancreatic cancer, very strong association of higher heart rate and poor outcome. And if you look into this a little bit from a ventricular tachycardia standpoint, you basically see that in these same 120 patients with 24-hour ECGs, we saw on average about 8% had non-sustained ventricular tachycardia in these patients, a little bit higher in pancreatic cancer, but very important, only 1 to 2% atrial fibrillation. Many people believe atrial fibrillation is a big issue in cancer. In a prospective study, it's actually a small issue, and I would like to highlight here the follow-up time. This was published in 21. The data cut was 2019. We started this in 2005 to 2007 to have this follow-up. And you can see here those with a non-sustained VT, they were all dead in 3 years. And you can see here, this is almost looking like animal research, but it is humans. When you had more than one non-sustained VT, everybody dead in 6 months. Okay, only 4 cases, but we are going to do this now in a much bigger analysis, I can promise you. Now, what about doing this retrospectively? You get much bigger numbers much more quickly. Well, suddenly you see atrial fibrillation 8 to 10%. This is published, this is our own Berlin data. Totally nonsensical, far too high numbers. And non-sustained VT, you actually find 17%. Don't forget, these patients get a 24-hour ECG by cardiologists. They're cared for in oncology for a reason. And these reasons make them prone to have more of these kind of problems. So it's totally biased. In a proper way done, you can only do this prospectively. Still, if you do this retrospectively, non-sustained VT is prognostic. So the therapeutic consequence of this is logical. We can discuss this. We are planning ICD trials, but we want to do this in patients with at least 2 non-sustained VTs in a 7-day ECG. These things are ongoing at the moment to have the epidemiological basis. So what about the cardiac wasting? Well, cardiac wasting, let's start with animals. As long back as 20 years ago, I've seen this data. This is Amgen data. Amgen takes about, from discovery to publication, 10 years for some of this stuff in their cachexia research. So cardiac wasting is long time known, of course, in cancer, published here in Cell and here then in 2010-11 in several other studies. We did a study in rats with cancer, and this is a liver cancer model. There's loss of lean and fat mass, there's loss of cardiac mass, and basically these animals have a very high mortality within 16 days. And you can see here that the body weight loss is late, after about day 11, and you also have a late loss in the heart wasting, so it showed it's a bit bigger. Really, you have a dramatic reduction in the end of cardiac rate, which for the left ventricle amounts to 58%. The left ventricles are essentially disappearing. Of course, in many other places, you couldn't do this research. We have special ethics permission because any cancer model must be killed, the animal, if there is 20% weight loss. We have special dispensation for an extra 3 days, and that's why this was possible with veterinary controls every 12 hours for these animals. It's a tricky business to do this. So basically what you then see in more detail is ejection fraction changes happen only at the very end. Now, how often have you actually done an echo in a palliative care or hospice patient in cancer? Never. That's why you don't see the low ejection fractions at the very end. Cardiac output then suddenly goes down at the very end together with the LV mass change. Here you see also contractility impairments. And funny enough, you also have QRS prolongation. And of course, heart rate variability goes totally down. These are super sick kind of animals. Moving on to the human scenario here, you can basically see then also fibrosis in the heart, and all of this associated with cancer and cachexia. That's where you have the real increase in natriuretic peptides, and that's where also in human cancer, this is 6 patients done in an autopsy, we found this. Now, the heart rate, as I said, goes down at the very late stage, and this is associated with fibrosis. Now, why is this heart failure? Well, this is the normal heart, and this is basically here dilated cardiomyopathy. You have a increased dimension of the heart. The LV mass goes even up, but the ratio is impaired, and so wall stress goes up, and so in the end you have heart failure development. So here's what you have in cancer. There is no dilation. If anything, the ventricles might even become smaller. But you have wasting of the LV mass, and the wall stress goes up. So that's also heart failure, just as cardiac wasting cardiomyopathy. So does this happen? It does happen. This is heart failure patients. This is healthy controls. This is all 300 cancer patients. 87 of them cachectic. This is non-cachectic patients. This is officially still unpublished, but I hope that I could say next week that this is accepted in JAC. It's in the 3rd revision. They want us to shorten the number of words in the figure legends. Technically not accepted yet, but it essentially is accepted. Chemotherapy makes no difference to the LV mass of these patients. So here you have anti-cancer therapy naive patients, non-cardiotoxic anti-cancer therapy, cardiotoxic anti-cancer therapy, no difference on average. This is a different kind of a problem. What about LV mass over time? Well, this is 90 echoes done twice. Average time of follow-up 4 months, 4 months, 4 months. And you have an average loss of LV mass of 9%. These are all, 85% are advanced cancer, stage 3B and 4, all of them are in palliative care. These are sick patients. And if you look here into reductions of LV mass of at least 5%, it's 2/3, but 44% was LV mass loss of at least 10%. So what is the therapeutic consequence? Well, last thing I want to tell you, and we have now randomized 4 patients, and we hope to do this overall in at least 72 patients. It's a BfArM approved trial that we are doing in this kind of patients. This is a group of patients assessed in the hospice palliative care scenario. The median survival of these patients is 51 days. 51 days. So now basically 66 years of age, and I don't want to bother you with all their cancer characteristics, but basically not able to walk 4 meters, half of them. On the day of accident, not even 4 meters, not from here to this thing. But if you can't walk 4 meters, you cannot go to the shower, you can't go to the toilet. So your independence at the end of life is finished. So here's the ability to wash yourselves on the day of examination and the previous days. This is a new kind of endpoint, days alive and being able to wash yourselves. The regulatory people love it. The payers love it because the biggest effort in these these patients is actually to wash them. And the biggest negative for their quality of life and for their dignity is the ability to wash. So this is basically what we are now doing. We have a clinical trial trying to prove that this is heart failure, but also trying to make a difference for the patients. So this is what they're getting. Sacubitril valsartan, ivabradine. You might say, why not a beta blocker? Beta blockers make quality of life bad. We want basically the patients with high heart rate to get ivabradine. When the blood pressure is at least 100, they get sacubitril valsartan. If they have iron deficiency, surprisingly only 20 to 30% have iron deficiency, not so many. They get, of course, iron deficient here, and then empagliflozin if the blood pressure is at least 95. They get this or nothing. All or nothing. They get just one heart failure therapy, 30 days. We expect that even in 30 days we will have 20-25% mortality. We will give them another 30 days of open label therapy and see what happens. As I said, the trial is ongoing, is funded, and let's see whether cardiac wasting cardiomyopathy as a therapeutic target works, whether they truly have also, from a therapeutic test standpoint, heart failure. Arrhythmias they have as well, but this is the near future. In any case, this has immediate research and therapeutic consequences, only possible in the prospective settings. Heart failure therapies, I think, are an option. Other devices maybe as well. That's why I said we use the RETS device in these patients, for instance. Let's see what else we can do. Thank you so much for your attention.
So, why am I not surprised to hear this from you? Stephen always comes up with novel ideas, out of the box thinking. Any quick comments? John, are you online?
Oh, yes, I'm online, and I've been happy to hear Stefan's talk, and I have been witness to the development of this talk for the last 20 plus years, and it's been fantastic to see where it's brought everyone. I think it's a very going to be very fruitful line of investigation. I don't have any specific questions for him except, good luck with the trials, and looking forward to trying to participate in some.
Thank you.
Okay, which I just wanted to ask you is, yes, making quality of life better till the time the person survives is an important thing, but the determinant of the mortality is predominantly the ongoing cancer, which possibly is out of bounds many a times. So ICD is still questionable in these situations.
Anyway, let me say it this way. I had a number of these kind of discussions in the past. Let me first of all say about our trial. The oncologists insisted for the patient disclosure form that one side effect could be that they live longer. It's a side effect, longer suffering. And absolutely the same is actually already agreed with the ethics committee for the ICD study. We must tell the patient that they may live longer. And they must, of course, totally understand this aspect. I personally think that under aggressive antiarrhythmic therapy, and I would put ICDs under this, you may even be able to give more aggressive chemotherapy. So there's more lines of idea. This idea, for instance, I don't know how many times, not many times, but a few times you have seen very successful phase 2 tested anti-cancer therapies being stopped in development because of arrhythmia development. And with you could suddenly rescue some of these anti-cancer therapies. I personally think that cardiovascular death, if properly assessed, is possibly not 1/4, but 30 to 40% of all deaths in cancer. I strongly believe that with what we are doing here, that's my personal mission, we can improve pancreatic cancer survival by 6 months. That's the mission.
So, yes.
Could somebody help me to? I only understood radiation in the beginning, I think, but just speak up into the microphone. The microphone works, I'm sure. Yeah.
So the mediastinal radiation in patients with mediastinal secondaries, I've seen cardiac dysfunction, about ejection fraction coming 30-35%, patient going for pulmonary edema. But actually, this is actually reversible after 6 months, completely reversible. And the patient gets 60% almost normal ejection fraction. And just want to know how to, I followed up the patient, treating for the conventional cardiac failure. At the end of it, after 6 months, it was reversible, totally reversible. So your experience in this matter, I want.
Now, I think I got your question and your statement that basically patients with radiation therapy get cardiac dysfunction, but it is totally reversible. This is the reason why we are not doing it, because you can manage it and it's actually kind of boring. This is not a quality statement, it's just from a trialist statement, the problem is essentially solved. And so I want to do something where there is still a problem. What you're probably taking care of is stage 1 and stage 2 cancer patients. I'm talking stage 3B, which means no longer option for surgery, and stage 4, which means palliative care patients, and even if there is such a thing, stage 5, hospice care. That's where we are focusing, advanced cancer. What you're talking is probably much earlier.
So
No, I think last comment.
So
we're running
the
behind.
inclusion which you are doing in the terminal cancer, the hospice patients, have they received a chemotherapeutic agent earlier?
Of course.
Right.
Yes.
So it's inclusive of everything. So now the question is, what is your experience about whether cancer per se is more cardiotoxic or chemotherapy patients drugs are more cardiotoxic? Because we know that the higher the chemotherapeutic agent, the better novel, they are more cardiotoxic we are seeing. So
I can't make a value judgment what is more. They are both toxic, first. Second, when the cancer is toxic enough, metabolically toxic enough, that the whole body is becoming cachectic, then is when you see the cardiac wasting. And can I make one clinical statement? And this is important, I should have said this in the talk. Why are we missing the cardiac wasting? It's not only because of the late stage of the phenomenon. There's a second reason. Almost all echo departments in the world use body surface area adjustment. And the major message of the paper coming out will be, stop doing that. The adjustment shall not be body surface area. It can be height squared, maybe ideally, or no adjustment. But then for no adjustment, you have individual comparisons only. But if you want to have population comparisons, do adjustment by height and do men and women separately. But body surface is associated with body weight. So what you're doing is basically the shrinking LV mass is adjusted for the shrinking body weight. Therefore, the ratio stays the same and you're losing the clinical information.
Thank you, Stephen. Dr. Mittal, you can discuss this later. We are 20 minutes behind. So thank you, Stephen. Thanks a lot. And now we go on to the next session, which is a joint session with Heart Failure Society of America. Dr. Hari Krishnan and Dr. Ibrahim Uman, may I request you to join us.
Well, I have the absolute pleasure now of asking John Teerling to give the first presentation. What is next in the medical management of heart failure? John, over to you.
Fantastic. Let's see if this works. Are my slides showing?
Yes.
Fantastic. Well, thank you. Thanks so much. And once again, my apologies for not being able to get there. A virus decided that I should stay in San Francisco. So I've been here recovering. So my topic is, as Professor Anker suggested, is what is next in the medical management of heart failure. And I underline medical because there are so many amazing things going on right now in terms of devices, but I'm not going to address those. These are my disclosures. And I want to reinforce what's been said throughout this entire meeting, which is that we are now fortunate to have the 4 pillars of heart failure therapy, all 4 of which have been shown to save lives. And that is going to be crucial to our ongoing discussion, that these agents are agents that have been shown to save lives and therefore need to be implemented to their maximally tolerated doses initially before any other therapies get initiated. Now, one of the things that's evolved is this universal definition of heart failure. and the stages of heart failure, and the Heart Failure Association of India endorsed this universal definition, where there was a bit of a shift where stage A became at risk for heart failure patients. And then we moved on to the three classic stages of heart failure, going from pre-heart failure to heart failure, and then actually advanced heart failure. There was also now a codification of the definition of heart failure, continuing it to be a clinical syndrome, but once again determined by symptoms and or signs of heart failure that are caused by a structural and or functional cardiac abnormality, and corroborated. So we have an objective measure of saying there's at least elevated natriuretic peptides or objective evidence of a cardiogenic pulmonary or systemic congestion. These are important fundamental definitions, and the document is really quite informative, I think. And the three things I drew from it were that there's now an emphasis on the trajectory of heart failure, that the definition of worsening heart failure is now location independent. So it's not necessarily just a heart failure hospitalization, but it can be outpatient or actually emergency room or other areas. And also there's a more nuanced understanding of the role of ejection fraction. It's dynamic, it interacts with the pathophysiology and mechanisms of action of other therapies. So what about new approved drugs? Well, you already heard some mention of vericiguat. I may give perhaps a little different suggestion here. Of note that vericiguat works via the cyclic GMP enhancing pathways in the same method that's in one of the pathways that sacubitril valsartan works, as well as nitrates and hydralazine. And so this agent actually competes a bit with the sacubitril valsartan. In the Victoria trial, we have over 5,000 patients enrolled with symptomatic heart failure who were enrolled within 6 months of a heart failure event with mildly elevated natriuretic peptides, and randomized to either vericiguat or placebo, where the primary outcome measure was time to cardiovascular death or heart failure hospitalizations. As you've already seen, the trial was positive with a 10% relative risk reduction, an absolute risk reduction of 4.2% per patient per year, with an annual number needed to treat that's quite good at 24. This benefit was solely due to a benefit in terms of reduction in hospitalizations for heart failure. And once again, vericiguat had no beneficial effect on survival, on mortality. In general, the subgroup analyses demonstrate that this beneficial effect of vericiguat was consistent across the subgroups, suggesting that this was a very effective therapy, regardless of what subgroup was used. The one area of concern was the one that actually Professor Anker already mentioned, which is in the patients with NT-proBNPs, there was actually a trend in other analyses, a significant worsening of outcomes in the patients who had elevated NT-proBNPs at baseline. And this was studied a little more in depth by Justin Ezekowitz in this paper, where you can see on the bottom is the NT-proBNP at randomization. On the left, on the y-axis, is the treatment effect of vericiguat versus placebo, where below the line of 1 is a beneficial effect and above the line of 1 is a potential harm. And you can see that depending on whether you want to use the 95% confidence intervals or the actual mean, somewhere between 4,000 and 8,000, there is a significant, a potential worsening or lack of benefit from vericiguat in these patients. So as the NT-proBNP gets higher in these patients, the benefit gets less. And while you heard some people suggest that this is an agent for worsening heart failure, we have not only that it doesn't work as well in patients and may cause harm in patients with higher NT-proBNPs, but also if you look at patients who are enrolled, and on the x-axis, you have the time from their index hospitalization to when they were initiated on the vericiguat. On the y-axis, you have the incidence rate of the primary outcome. And you can see that in patients who are randomized while hospitalized, within 30 days, in 60 to 90 days, and 90 to 120 days, there was no beneficial effect of vericiguat. Most of the beneficial effect was actually isolated to patients who were enrolled 4 months or later in the trial. So this does not seem to actually support that this is for worsening heart failure. It's for patients who had a more distant history of worsening heart failure. In addition, you heard that there was no bad effect in terms of symptomatic hypotension or syncope, and the systolic blood pressure trajectory had an initial decrease in patients who were above 75 and with ARNI use, but then this returned to baseline. In patients with a systolic blood pressure less than 110, there was no initial change in the blood pressure. Also, the benefit of vericiguat was similar across baseline systolic blood pressure groups. Of note, on the right-hand side, you see the risk of symptomatic hypotension or syncope, which was not statistically, the 18% increase in the symptomatic hypotension or syncope was not statistically significant. Now, earlier you saw this slide saying, hey, vericiguat can be sparing of additional therapies. And I actually view these data as actually concerning because, as I mentioned before, sacubitril valsartan is a life-saving therapy. And the initiation of vericiguat in these patients actually prevented the initiation of life-saving sacubitril valsartan in the patients. And I think this only reinforces the importance that patients who need to be maximally tolerated sacubitril valsartan before they start vericiguat, so that they can get the maximum mortality benefit from the sacubitril valsartan before they get the heart failure hospitalization benefit from vericiguat. So then that's the drug that's just been approved, and I know it's available in India. Another investigational drug that's currently under regulatory review is omecamtiv mecarbil. This is an agent that improves cardiac function by improving the interaction between actin and myosin. In effect, it results in more hands pulling on the actin rope to produce more force with each beat. The GALACTIC-HF trial was published in 2021, had over 8,000 patients with New York Heart Association class 2 to 4, LVEFs less than or equal to 35% with elevated natriuretic peptides. And patients could be randomized in the trial whether they were hospitalized for heart failure, so they were inpatients, or within 1 year of a prior heart failure hospitalization, which were enrolled as outpatients. Importantly, patients could be enrolled in this trial with blood pressures as low as 85 and an eGFR as low as 20. The patients were randomized 1-to-1 to omecamtiv mecarbil and placebo, and the results are similar to vericiguat, where you have an 8% reduction in the time to first heart failure event or cardiovascular death that was driven predominantly by, or almost exclusively by decrease in heart failure hospitalizations. Now, we knew that omecamtiv mecarbil works by a mechanism of improving cardiac function. So therefore, and that purposely selected an ejection fraction of 35% or lower, knowing that we felt it would do better in patients with lower ejection fractions. And certainly that turned out to be the case. Here we have on the bottom, on the x-axis, the ejection fraction in percents, and on the y-axis, the hazard ratio for heart failure event or cardiovascular death. And you can see that with an ejection fraction of 30% or lower, you had a progressive improvement in the beneficial treatment effect of omecamtiv mecarbil, such that in the lowest ejection fraction quartile, the only number needed to treat got down to 13.5 patients to prevent one heart failure event or cardiovascular death per year. Interestingly, if you took the patients at the median, which was the pre-specified division, and you had then a number needed to treat down to 20. If you then added any other clinical factor, such as NYHA class 3, or an elevated NT-proBNP greater than 2,000, or systolic blood pressure less than 110, now your number needed to treat drops into the 12 to 14 range, suggesting that omecamtiv mecarbil actually works better in patients with more advanced, more severe, more symptomatic heart failure. Now, interestingly, there was one other significant treatment effect, and that was with respect to atrial fibrillation or flutter, where we saw that this modified the treatment effect of omecamtiv mecarbil. Patients without baseline AFib flutter derived greater benefit from omecamtiv mecarbil. And when we looked closer, well, what was the thing that was driving that? Patients with baseline AFib, and particularly those who were receiving digoxin, experienced a blunted treatment effect from omecamtiv mecarbil and actually had worse outcomes. And so this was an interesting and unexpected finding from GALACTIC-HF that we're investigating further. I mentioned before how with vericiguat, the beneficial effect got less with increasing NT-proBNPs. In contradistinction with omecamtiv mecarbil and GALACTIC-HF, while there is a improved outcomes regardless of the NT-proBNP, you can see that somewhere between 1,500 and 3,000, the higher the NT-proBNP, the more beneficial the treatment effect is with omecamtiv mecarbil. In addition, when we looked, and this is an article by Mike Felker, who looked at saying, well, if we look at any one of the agents, like if we looked at one of the factors, if you look at NYHA class 3 or heart failure hospitalization within 6 months or EF less than 30%, all of those end up getting about a 12% risk reduction. If you combine then into a surrogate for the ESC definition of advanced heart failure, severe heart failure, you now get a 20% relative risk reduction with an absolute reduction of 8.3 events per 100 patient years, are now down to a number needed to treat of 12. Reinforcing this concept that the more advanced patients seem to benefit better from omecamtiv mecarbil. Another interesting finding is that omecamtiv mecarbil decreased the risk of non-fatal and fatal stroke, no matter how we looked at it. And this was with 194 events, which is more events than occurred in any of the heart failure stroke trials. So we had a 35% reduction in non-fatal and fatal strokes, and granted on small number of events, 50 events, a 44% reduction in the fatal stroke. These were non-pre-specified, though stroke was a pre-specified endpoint in part of a composite. In addition, the total recurrent stroke events were significantly reduced as well. This is all in the context of having no significant effect on systolic blood pressure, adverse effect on heart rate, potassium, creatinine, and a significant reduction, 10% reduction in NT-proBNP. There was a marginal increase in cardiac troponin, which we've seen throughout the program, and Professor Felker has just produced a paper suggesting that that absolutely had no clinical adverse outcomes. So given this no adverse impact on heart rate, blood pressure, renal function, or potassium, and no difference in adverse events or serious adverse events, including specifically ventricular arrhythmias or ischemic events, we feel that this agent is very useful in terms of adding to the current armamentarium. So what about things that we'll discuss later in terms of other investigational drugs include serelaxin and istaroxime? But what about agents that are targeting improving cardiac performance? Well, we've looked at this, and the term inotrope is a little too general. So cardiac calcitropes are agents that improve cardiac function by altering intracellular calcium. Mitotropes improve cardiac function by influencing energetics, and myotropes affect the molecular and motor and scaffolding. Some cardiac calcitropes, obviously istaroxime will be discussed. And then there are the beta-3 adrenergic receptor antagonists, which may work through a calcitropic mechanism. Cardiac beta-3 adrenergic receptors are increased in multiple models of heart failure, and they are resistant to chronic catecholamine-induced desensitization. The increased activation of these agents is thought to be protective in counterbalancing the excessive activation of these catecholamines. And so there's the thought that if you can antagonize these agents, you can actually improve cardiac function. In a small study by Tony Sabah, in dogs with heart failure due to coronary microembolization, there is in fact an improvement in ejection fraction, cardiac output, as well as some measures of diastolic function in dogs when they are administered this beta-3 adrenergic receptor antagonist. So this is a potential future direction in terms of a cardiac calcitrope. What about mitotropes? I recognize that actually trimetazine and perhexaline may be used quite well in India. Also, there's a question of whether SGLT2 inhibitors work via a mitotropic effect. And then finally, there are the ketone bodies. The ketone bodies, such as 3-hydroxybutyrate and acetoacetate, maintain ATP generation in the vital organs. And these ketone bodies actually provide more energy per 2-carbon moiety than glucose and require less oxygen for ATP generation than the fatty acids. And so there's a suggestion if one can actually increase these ketone bodies, you can treat both acute heart failure as well as chronic heart failure. And this is a small study using 3-OHB in 3-hydroxybutyrate in patients with heart failure, EF's 37%, showing that these patients actually had an improvement in cardiac output and stroke volume with a marginal increase in oxygen consumption, and no different and decrease in systemic vascular resistance, suggesting that this may actually be a useful direction for future therapies, and one that currently there are at least 5 trials that I saw with this approach going on now. So what about myotropes? Well, I've already talked about omecamtiv mecarbil, and there are certainly other troponin and myosin activators that are in development, and I look forward to seeing how these progress as well. There's also multiple selected new therapeutic directions. I could only put a few here. Some included the myeloperoxidase inhibition agents. This is targeting HFpEF indirect, phosphodiesterase 9 inhibition, which is targeting both HFpEF and HFrEF and has an ongoing trial. Partial fatty oxidation inhibitors, which are going along the metabolic pathway. This is a mitotrope, and this is the improved DICE trial that's ongoing. Then there are the mineralocorticoid receptor modulators that are trying to actually more finely tune the MRA pathway, such as balcinrenone, and there's a trial ongoing now called Miracle. And then there are the NPR, the natriuretic peptide receptor 1 agonists, which are in studies now with Regeneron. The other thing that we have to look forward to is just an increasing understanding of the pathophysiology of heart failure. And this is just one of a slew of fantastic articles that are looking at the current heart pathophysiology of HFpEF, looking at HFpEF as a cardiometabolic disease. I won't go through all of these pathways, but I just want to point out that each one of those targets that are in bold on the left-hand side are potential therapeutic targets for us to work and try to modify the course of HFpEF. And there are obviously multiple other theories ongoing. There's a more inflammatory theory. There's the pericardial adipose tissue theory, all of which actually work together to talk about the pathophysiology of HFpEF. So what is next in medical management of heart failure? Well, I think there's an exciting new understanding of the pathophysiology and diversity of heart failure. We're going to need to get towards patient-specific approaches to heart failure. I think there are going to be continued discovery of innovative therapeutic approaches. And then there needs to be evolving work on implementation of our therapeutic successes. And in my closing talk, I'll have the opportunity to talk more on that later. So thanks very much for your attention and looking forward to any questions.
Thank you, John, for that wonderful discussion of the newer modalities of heart failure which are emerging. Any questions from the floor? Yeah, please. Can you give a mic? Otherwise, John will not be able to hear.
Yeah, sorry, I can't hear you. And you may need to repeat it for me.
Sir, we'll repeat.
I want to ask that is possibility of using omecamtiv mecarbil in cardiogenic shock. Are there any studies?
So great question. My understanding is there any studies of omecamtiv mecarbil in cardiogenic shock? There is not. We did do the atomic AHF trial, which is in patients who were admitted with acute heart failure, and we immediately treated those patients with omecamtiv mecarbil. In the patients who had plasma concentrations that were at the level that we're now studying clinically, those patients had an improvement in dyspnea with acute heart failure, but we actually excluded cardiogenic shock from that trial. And certainly as we learn more about the approval process and regulatory pathways, that is certainly an interesting direction for omecamtiv mecarbil. So great question. Yeah.
Thanks.
Uday, you wanted to make a comment?
Well, I'm not a cardiologist, as I said yesterday, but I have lived with a cardiac patient, my own mother. This is to Professor Stephen, who also said he had some personal experience. I'm 33 years in service, 60 years now. But when I joined JIPMA at the age of 18, my mother went into heart failure. She was RHD with mitral stenosis, with critical mitral stenosis in 81. And she lived up to 89 to see my other siblings, 2 other brothers, who joined JIPMA. We were 2 years younger to each other. She made 3 JIPMA MBBS graduates. She came for our graduation ceremony, lived with heart failure, RHD.
What is your
Yes,
query?
I want to say, so many drugs and newer drugs are being coming into the market, but where are we going? And we have, I was astonished to see, but it's all nice. We need science progression. Last 8 years, there have been a new association for heart failure itself. And this is the 9th year we are going with more drugs.
Thank you.
But those days, it
Thank
was
you.
just
John,
digital. Digoxin and Lasix was the only things that when spironolactone came. And she was put on acetylene for
Thank you.
atrial fibrillation.
We understood the point.
But
John, any comments on that?
But it's all said done, as he said, congestive heart failure is a downhill thing. We are only prolonging. But still,
it doesn't need to
9
be a
years,
downhill thing.
I want to
It
know
doesn't need to-
for him, how many years any patient you would have taken
Can we
for
discuss
9 years?
this? See, this is not part of the discussion. We can discuss it
No,
later
so
on.
much therapeutics is going on,
we
sir.
can
That's
discuss
why.
it later on, please.
Yeah, any other, I think we are running 30 minutes short of the schedule, so shall we move forward? Okay.
Role of microRNAs.
MicroRNA in cardiogenic shock.
John, brief comment on that.
So I think microRNAs are really a promising direction in the future, and we have some small trials. I don't know of any specifically in cardiogenic shock. I do know of some in regular heart failure, and those are small pilot studies that have looked promising, but still I think we have a long way to go. I think this is an area though where our understanding of basic science is really going to help us move forward.
Thank you. We will go to the next talk. It is recorded. Dr. James Fang on head-to-head comparison between recommendations by the ESC and ACC, AHA, HFSA, heart failure guidelines. Over to the recorded talk from Dr. James Fang.
Hello, my name is James Fang. I'm here at the University of Utah. And I want to thank the organizers for inviting me to speak at the Heart Failure Association of India. I'll be speaking today about the differences between the American and the European guidelines. I know you've had a long 3 days, and I hope to keep your attention for the next 10 to 15 minutes. These are my disclosures. Well, to take a 30,000-foot view of the guidelines, these were incredible efforts of both the European and American committees. They were released within months of each other. The European guidelines were released in August of 2021, and 7 months later, the American guidelines were released. These were, again, enormous efforts, numbering more than 100 pages in both instances, containing dozens of recommendations and hundreds of references. I do think it's important to consider the documents with respect to the nature of their recommendations and the evidence to support them. So as you can see here, where I've summarized the percentages of the different classes of recommendations, less than half the recommendations in either guideline were class 1 recommendations. In fact, the majority of the recommendations were class 2, giving a lot of discretion to providers. Importantly, the American guidelines, almost 14% of the recommendations were class 3, suggesting that there are very specific issues the American guidelines wanted providers not to do. If we move on to the level of evidence used to support these guidelines, you can see that the two documents were similar with respect to the use of large prospective randomized trials to support recommendations. Generally, 15 to 20% of these recommendations were supported with such evidence. I think an important difference here was the nature of using clinical consensus to support the recommendations. Almost half the recommendations in the European guidelines use this level of evidence to support the recommendations. In contrast, the American guidelines only used about 25% of their recommendations using clinical consensus evidence. Well, there are a number of areas that could be compared and contrasted over the next 10 to 15 minutes, and this is a very nice summary figure from Tony Bay's genus in the European Journal of Heart Failure just last year. He broke it down into six categories, looking at the prediction of disease trajectories, diagnosis, risk factors for heart failure, treatment of reduced and mildly reduced ejection fraction, preserved ejection fraction therapy, and the management of acute and advanced heart failure. I think I'll spend the next 10 to 15 minutes concentrating on treatment, where I think most providers spend most of their time in the practice of heart failure management. I would also comment that the American guidelines were also very focused on cost effectiveness and disparities of care, where the European guidelines, as we'll talk a little bit about, spend a little bit more time being more specific about treatment of comorbidities. Well, to emphasize this issue of how important the differences and similarities of heart failure treatment should be highlighted, I'd like to just take the top 5, the top 10 take-home points that the American guidelines wanted featured and highlighted. And this included that there were now 4 pillars of classes of medications that served as guideline-directed medical therapy for heart failure reduced ejection fraction, and now include sodium glucose cotransporter type 2 inhibitors. Importantly, SGLT2 inhibitors now have a class 2A recommendation in both sets of guidelines, European and American, for mildly reduced ejection fraction. The American guidelines now specifically have recommendations for preserved ejection fraction. The entity of heart failure with improved ejection fraction is specifically called out in the American guidelines, and as I'll discuss, is not called out in the European guidelines. And very importantly, the American guidelines spent a fair bit of time discussing the cost effectiveness of various interventions. Now, to start with reduced ejection fraction, what I've provided you here are the levels of recommendations for the treatment of reduced ejection fraction by class of drug. Now, both recommendations agree that RAS inhibitors, beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors should be considered pillars and cornerstones of reduced ejection fraction heart failure management. Where they differ is the use of the RAS inhibitor ARNIs, or sacubitril valsartan, specifically for the initial de novo management of patients with reduced ejection fraction. The American guidelines have suggested that patients with mild and moderate heart failure should be considered for ARNI therapy as de novo primary therapy in conjunction with ACE inhibitors or ARBs. In contrast, the European guidelines stuck really with the paradigm clinical trial and suggested that the only class 1 recommendation for an ARNI was in the instance where patients were already on ACE inhibitors or ARBs and could be changed over. Using an ACE inhibitor remained a class 1 recommendation, which is similar to the American guidelines. Why this difference? Primarily because I think the American committee felt that other clinical trials and other data sets did support the use of ARNIs for the initial management of patients with reduced ejection fraction. Specifically, the Pioneer and Transition trials were highly suggestive of the fact that patients initiated in ARNIs would do quite well, in contrast to patients with ARBs or ACE inhibitors. In fact, 50% of the patients in Pioneer were getting treated de novo, and almost 25% in the Transition trial of QT compensated heart failure were being treated as de novo therapy. I think one of the most important differences between the two guideline recommendations is in the treatment of heart failure with preserved ejection fraction. As you can see here on the left, the American guidelines, in addition to diuretics, have specific call-outs to several classes of medications for the treatment of preserved ejection fraction, specifically SGLT2 inhibitors, ARNIs, melanocortin receptor antagonists, and ARBs. In contrast, on the right, the European guidelines really only just call out the use of diuretics and talk a little bit about the treatment of comorbidities as a class 1 recommendation for the treatment of HFpEF. Now, this important difference was in large part driven by the fact that the Emperor Preserved trial had not been released at the time the European guidelines were released, so they did not have that clinical trial data set to review in order to make their recommendations. Another important difference was the interpretation of the Paragon trial and post hoc analyses of TOPCAT and the CHARM program of clinical trials. The American Guideline Committee felt that the weight of evidence in these clinical trials supported at least a 2B recommendation, albeit weak, for the use of these classes of drugs for the management of patients with heart failure with preserved ejection fraction. It's important to recognize that both guideline committees have now acknowledged the presence of heart failure with mildly reduced ejection fraction or those patients with LVEFs between 40 to 50%, which is a very common clinical scenario. The American guidelines on the left, again, call out, in addition to diuretics, several classes that are the same as the 4 pillars for reduced ejection fraction, specifically SGLT2 inhibitors, RAS inhibitors, melanocortin receptor antagonists, and evidence-based beta blockers. The European guidelines likewise acknowledge the use of these classes for patients with mildly reduced ejection fraction, again, in large part due to a review of the clinical trials, particularly when the clinical trial evidence was combined in either meta-analyses or in specific post hoc examinations of the clinical trials where patients with ejection fractions of 40 to 50% were included. I think a major difference was the nature of the evidence that the two guideline committees thought supported these recommendations. In the case of the European guidelines, this was really felt to be from clinical consensus. In contrast, the American Guideline Committee felt that the weight of the evidence lied within various data sets from clinical trials and observational data sets. How about additional therapies for patients with reduced ejection fraction? The American guidelines specifically call out ivabradine, vericiguat, digoxin, fish oil, and potassium binders. The European guidelines similarly support ivabradine at a 2A, vericiguat at a 2B, and digoxin as a 2B. However, the European guidelines did not call out fish oil or potassium binders. I should note that the potassium binder recommendation in the American guidelines is a relatively weak one, and in fact, the American guidelines acknowledge that the benefits are uncertain, but felt that 2B recommendation was warranted. How about the use of hydralazine and isodil? I put these recommendations here on the right for the European guidelines. As you can see, that they were given a 2A recommendation, basically paralleling the inclusion criteria for the AHF trial of patients with who were self-declared African American who had HFrEF. The idea that this combination of drugs could be used in patients who are intolerant of RAS inhibitors garnered a 2B recommendation. In the American guidelines, in contrast, felt that the weight of the AHF trial should warrant a class 1 recommendation, keeping in mind it was one single trial, modest in size, and stopped early by the Data Safety Monitoring Board. But the American Guideline Committee also agreed that the use of this combination was very reasonable, primarily due to the view by clinical consensus that this is a clinical common scenario and routinely done without any known significant harm. One thing the American guidelines did call out was this issue of sequencing and up titration. Although both guidelines acknowledge that these drugs are best used at the doses studied in the clinical trials, the American guidelines called this out as a recommendation, noting that it was very important to push these drugs to the target dose used in the trials, and that importantly, this would be done very quickly, burning it to a recommendation. Again, this is noted in the European guidelines, but not a specific recommendation. The American guidelines also called out drugs that they felt providers should acknowledge were harmful to patients with heart failure with reduced ejection fraction in particular. And as you can see here from this summary, that these classes include class 1 antiarrhythmics, TZDs, DPP-4 inhibitors, and non-steroidal anti-inflammatory agents. You can see the weight of the evidence there in the middle column. One particular phenotype of heart failure that was also specifically called out in the American guidelines are those patients with heart failure with improved ejection fraction, often defined by an ejection fraction that starts below 40% to rises above 40% with at least a 10% absolute increase. In this case, the recommendation was that these patients should not have their drugs stopped or titrated down. We also now know from the DELIVER trial that patients in this category do benefit from the addition of SGLT2 inhibitors. Well, there are a number of other additional therapies that can be considered in patients with heart failure, and this is a figure from the American guidelines. I just wanted to really call out one specific issue, and that was iron. While the American guidelines acknowledge that iron deficiency should be sought, the European guidelines note that this should be done periodically in a patient's clinical course. And number two, that they call out a specific type of intravenous iron supplementation, specifically ferric carboxy maltose, which is not done in the American guidelines. And in the European guidelines, this was given a 2A recommendation. In the hospitalized patient, diuretic use is covered quite completely in both guidelines. But in addition to the use of diuretics to achieve decongestion, and that there should be a plan for the use of diuretics at the time of discharge, the European guidelines incorporate the use of urinary sodium concentration to assess the efficacy of diuretic therapy. And this is not done in the American guidelines. This has not yet subjected to large-scale randomized outcome trials, but I think is an important thing to note with respect to differences between the two guidelines. And then finally, the American guidelines do spend quite a bit of time talking about cost effectiveness and the value of various treatments that have been established from large-scale randomized trials, using a cutoff of $60,000 per adjusted quality of life year, defining high value, and greater than $100,000 per adjusted quality of life year, defining low value. You can see from these next two tables that the 4 pillars of heart failure with reduced ejection fraction therapy provide high value. RAS inhibitors, beta blockers, MRAs, and even hydralazine isodil. A particular note, both ICDs and CRT also provide high treatment value. Of lesser value or unclear value are things like SGLT2 inhibitors, which will almost certainly become high value over time. Heart transplantation, tafamidis, because of its exorbitant cost, is particularly notable for its low cost effectiveness now. And then the use of LVADs and hemodynamic monitors remain uncertain. Well, I hope over the last 10 to 15 minutes, I've highlighted what I thought were important differences between the two. guidelines. Here's a summary slide that provides what I've discussed, importantly noting that both guidelines acknowledge the 4 pillars for HFrEF therapy. The American guidelines being a little stronger with the use of farnesis de novo therapy. Hydrolysis and isogel really being a class 1 recommendation in the American guidelines, 2A in the European guidelines. That the mid-range ejection fraction therapies really are similar between the 2 guidelines, although the weight of the evidence is defined by clinical consensus in the European guidelines and class B in the American guidelines. And then finally, and I think most importantly, the American guidelines call out specific classes of drugs for HFpEF therapy in contrast to the European guidelines. That was a bit of a whirlwind, many other topics to have covered, but in the time allotted, I've hopefully highlighted what will be important to the audience today. Thank you very much.
John? Oh, hi. Hello, Dr. Fang. What's that? Is he live? No. Okay. Okay.
No, yeah.
Yes, John, since we are slightly late, can you summarize in about 30 seconds, are there any important differences between the two? Or is it just that the guidelines were published about a year apart, so there are some differences, apart from mention of improved HF in one of the guidelines?
I think there are subtle differences between the guidelines. I think you pointed out that the fact that they were separated by 1 year and the ACC, AHA, HFSA guidelines had the advantage of that. And as you notice, they didn't even have deliver. So, the good news is our field is continuing evolving. The bad news is our field is continuing evolving. And so our guidelines become very rapidly out of date in many ways, which is why we need to try to find ways to have more rapid updates in the guidelines. But otherwise, I think they're very consistent.
So, Bayan, yes, Dr. Shastri, last one comment only. So the message is
while formulating the guidelines, what is the influence of the political system, economy, regulatory authorities? Yesterday, someone was saying in Europe they are more socialist and the delivery system and the cost factor. The way the healthcare is delivered in Europe is different from how it is in the US versus what is in India. So what is the influence of these background systems on the development formulation of the guidelines?
John?
So this is why actually the ACC, AHA, HFSA guidelines split out the 2 things. There's the regular recommendations, which are based on the scientific backgrounds of the clinical trials. And then there's an adjoining value statement in terms of what the economic impact is of those agents within the US context. And so that's how that's addressed in the US guidelines. I don't think, that's not addressed in the EC guidelines, but every country has to deal with this on their own basis in terms of what's available. One of the criteria is that the drug has to be available to get into the guidelines. And so, if it's not approved, it doesn't get into the guidelines. Sometimes it has mention, but it has to be, in order to get actually a recommendation, it has to be available in the United States, and I also believe in at least some countries in the ESC.
Also, a lot of it depends upon the cost of drug in that particular country also, which decides, how many dollars per disability adjusted life year. Absolutely. Okay, I think we'll go on to the next talk, which is now the time for sex-specific guidelines in heart failure by Dr. Michelle Kittleson. Again, this is a recorded talk. Can we have the talk, please?
Hi there. I'm Dr. Michelle Kittleson from the Smith Heart Institute at Cedars-Sinai in Los Angeles, California, USA. And I'm going to talk to you about, is now the time for sex-specific guidelines in heart failure? So when we think about sex-specific guidelines in heart failure, we need to think about the clinical trial outcomes of guideline-directed medical therapy, the outcomes of cardiac resynchronization therapy, and what does it mean to reach target doses of GDMT from a sex-specific perspective. And we'll start first with heart failure with reduced ejection fraction. When we think about heart failure with reduced ejection fraction, the 4 pillars of survival enhancing medical therapy, the best therapy you can provide your patient is the ARNI, the beta blocker, the mineralocorticoid antagonist, and the SGLT2 inhibitor. So now let's talk about the data underpinning these various therapies and how it differs in men versus women. So beta blockers, it's pretty clear, save lives. And we can see in the landmark trials of beta blockers in HFrEF, only a small proportion of patients are women, around 20%. And the variability of benefit in subgroup analyses is men or men and women both. But in patients who are less sick, really sick, after myocardial infarction, there is overall a reduction in mortality, which is why the 2022 ACC, AHA, HFSA guidelines tell us that in patients with HFrEF, one of the 3 evidence-based beta blockers is recommended to reduce mortality and hospitalizations. ACE inhibitors also save lives. And while I'm not going to go through this slide in exhaustive detail, I have to call your attention to the consensus trial, which came out in 1987. It enrolled the sickest patients, NYHA class 4, only 253 patients, only followed for 6 months, yet there was a significant reduction in mortality, 26% mortality versus 44%. It's hard now to imagine living in a world where your patient with HFrEF has a 44% chance of dying at 6 months, and that's largely due to ACE inhibitors. And while there is generally a small proportion of women in these trials, and there's not clear mortality benefit that's sex specific, we know that in patients who are really sick, less sick, asymptomatic after MI, there is a reduction in mortality. Now, we know that the beta blockers target the sympathetic nervous system, and the ACE inhibitors target the renin-angiotensin-aldosterone system, but there's a third important neurohormonal axis that we shouldn't forget, and that's the natriuretic peptide system. And the natriuretic peptide system is where the angiotensin receptor neprilysin inhibitor comes in, as the neprilysin inhibitor sacubitril increases endogenous natriuretic peptides. The theoretical benefit of natriuretic peptides was put into practice in the Paradigm HF study, head-to-head trial of sacubitril valsartan versus enalapril, the reigning king of the day. And in fact, sacubitril valsartan knocked enalapril off its throne with a significant reduction in cardiovascular death and heart failure hospitalizations, a benefit in both men and women. And that is why the 2022 heart failure guidelines are very clear. An ARNI is recommended in symptomatic HFrEF, ACE inhibitor only when ARNI is not feasible, and an ARB only in those patients who are intolerant to an ACE and ARNI is not feasible. The guidelines go so far as to say in patients who are already on an ACE or an ARB, replacement by an ARNI is recommended. The mineralocorticoid antagonists round out our renin-angiotensin-aldosterone axis, and we see that again, a relatively small proportion of patients in the clinical trials are women. But there's benefit in both subgroups depending on the trial. Patients who are less sick post-MI, a reduction in mortality. But I call your attention to the observational study highlighted here. Note that 50% of patients in this observational analysis were women. This is quite interesting. This observational analysis took prescription claims data and hospital records for Canada in patients over 66 and looked at 2 time points, 1994 and 2001, examining spironolactone prescriptions, hyperkalemia hospitalizations, and hyperkalemia deaths at the 2 time points. They found that prescriptions went up, likely because after the publication of Rawls in 1999, more clinicians were prescribing the MRAs to treat their patients with heart failure. But they also found that deaths and hospitalizations for hyperkalemia rose. And that has a lot to do with the application of clinical trial conclusions to populations that are outside the clinical trial eligibility. And part of that might have been the significant inclusion of women who have a lower EGFR for the same creatinine as men, and thus more prone to hyperkalemia. Now, that's why the guidelines, while they give a strong class 1 recommendation to the mineralocorticoid antagonists, recommend close attention to the EGFR and the potassium. Now, the final pillar of HFrEF therapy is, of course, the magical and mysterious SGLT2 inhibitors. They initially were used for diabetes because of their impact on glycemic control through glucosuria. But they also cause natriuresis, which can improve volume, overload, and blood pressure, and also have other effects on oxidative stress, inflammation, fibrosis. And that led to the important SGLT2 inhibitor heart failure trials. Again, we have DAPA-HF and Emperor-produced, the two most important trials, very small proportion of women. Significant benefit in subgroups varies. DAPA-HF was very important in that the trial came out at the ESC meeting in September 2019, and less than a year later, the United States Food and Drug Administration had extended the indication to patients with HFrEF without diabetes. So powerful was the data from DAPA-HF. Emperor-Reduce extended this. The results were not as dramatic. There was not a reduction in cardiovascular death, but there was a reduction in heart failure hospitalizations. It's likely still a class effect. Empagliflozin is likely just as good as dapagliflozin. It's important to note that the population of Emperor-Reduced was sicker, lower median EF, higher median BNP, and the point estimates for event rates in the placebo group were much higher. Soloist WHF tells us that acute initiation in the hospital is safe. So the guidelines support this, telling us that in symptomatic HFrEF, SGLT2 inhibitors are indicated regardless of the presence of diabetes. So there you have it, the 4 pillars. What about cardiac resynchronization therapy? We all know it's indicated for patients with symptomatic HFrEF, left bundle, wide QRS. But now we look at pooled data from 3 CRTD versus ICD trials. It's about 4,000 patients, about 22% women. If we stratify by QRS width, we see that men and women both benefit if the QRS is above 150 milliseconds. But if the QRS is 130 to 149 milliseconds, women benefit from CRTD and men do not. So likely there is some sex-specific difference in the impact of QRS duration on dyssynchrony and thus benefit of CRTD. What about doses of GDMT and HFrEF? This is a post hoc analysis of Biostat CHF, a registry of 1,700 patients with HFrEF, validated in Asian HF, a registry of 4,500 patients. And we can see that when it comes to men, looking at ACE inhibitors, ARBs, beta blockers, the lowest risk of mortality and heart failure hospitalization happens at 100% of target doses. But in women, the lowest risk of death and heart failure hospitalization happens at 50% of target dose with no further benefit. What does this tell us? That while we strive so hard to reach target doses, maybe there should be sex-specific thresholds for what that means. So that takes us through HFrEF. Now let's turn our attention to HFpEF. So HFpEF, the 2022 guidelines tell us that diuretics are the strongest indication that is used for symptomatic relief of congestion. Other than that, we have weaker indications for the SGLT2 inhibitor, the ARNI, the MRA, and the ARB. So let's consider what GDMT exists. What is the evidence behind the GDMT of HFpEF? So spironolactone is an interesting story. We had the classic TopCat trial. It came out in 2014, over 3,400 patients, notably 52% women, as HFpEF is more common in women. Heart failure hospitalizations were reduced. There was an expected increase in potassium and creatinine in those patients on spironolactone, and the benefit was seen in both men and women. But the primary endpoint of this trial was not met, which was a real disappointment. But what's very interesting is if you look at this geographical subgroup analysis, you see that half the patients in the trial were enrolled in Russia and Georgia. And if you look at the outcome rate in patients enrolled in Russia and Georgia compared to the Americas, it's strangely reduced. 2.6 versus 3.4%. And patients ostensibly taking therapy in Russia and Georgia did not have a rise in potassium and creatinine. So this is all very unusual and led to the concern of nefarious clinical trial doings that perhaps patients in Russia and Georgia were enrolled not meeting HFpEF clinical criteria and perhaps didn't receive study drug. Well, the guidelines tell us that in selected patients with HFpEF, MRAs may be considered. The guidelines can't consider these subgroup analyses as powerful indications to give therapy, and that's why MRAs, despite this compelling geographical subgroup analysis, have a relatively weak indication. What about sacubitril valsartan? Well, we have the Paragon HF study, 4,800 patients, again, 52% women, because HFpEF is common in women. We see that heart failure hospitalizations were almost significantly reduced, p-value 0.06. And if you look at the subgroup analysis, you see there was benefit in women compared to men, and those with an ejection fraction on the lower end of the spectrum of HFpEF. The guidelines, again, tell us that in select patients, it may be considered, again, a to be indication, as the primary endpoint was not met, and there was only benefit in subgroup analyses. Finally, we have the SGLT2 inhibitors. I've saved the best for last. I think this is incredibly important, incredibly exciting data. When we look at the SGLT2 inhibitors in HFpEF, we have 2 trials now, Emperor Preserved and Deliver, both about 6,000 patients, both about half women. In both, there was benefit in both male and female subgroups of a reduction in the primary endpoint of combined death and heart failure hospitalization, driven by a significant reduction in heart failure hospitalization. The guidelines give the strongest indication for any GDMT in HFpEF to the SGLT2 inhibitors, as they are the only medications in HFpEF ever to meet their primary endpoint, can be beneficial in decreasing heart failure hospitalizations. And I suspect, as the guidelines were based just on Emperor Preserved and Deliver was published subsequently, that stronger recommendations may manifest in the future. So coming back to the question we started with, is now the time for sex-specific guidelines in heart failure? Well, I think the answer is not yet. Because if there's one thing we have to remember of the wealth of evidence I've shown you, of the whirlwind I've taken you through, of the classic clinical trial findings of guideline-directed medical therapy in HFrEF and HFpEF, the one thing we always have to remember is that subgroup analyses are hypothesis generating, and thus the best data we have is to include all therapies that have been shown beneficial for all patients. So I'll give you my take on therapy. When it comes to HFrEF by the guidelines, the 4 pillars that all patients should be prescribed for optimal therapy are the ARNI, the beta blocker, the MRA, and the SGLT2 inhibitor. In select populations, hydralazine nitrates, defibrillators, CRTD, and then in even more select populations, ivabradine, varisequat, and digoxin. My take is you start the 4 pillars. You titrate to max tolerated doses. You use other medications in special situations. You do not use sex-specific criteria in HFrEF because of the wealth of strong evidence that these patients benefit regardless of sex. You should not be denying these therapies just because a subgroup analysis may or may not have shown benefit for women. Apply the trial guidelines. Now, the story for HFpEF is a little different because we don't have this wealth of incredibly strong evidence. So my take, when you think about the array of therapies available to you, is start the SGLT2 inhibitor, strongest evidence, add the MRA based on the strength of the top cat subgroup analysis, and then I would employ a sex-specific threshold of the ARNI in women based on Paragon-HF if the blood pressure, potassium, and creatinine allow. And that is my take on how we interpret the sex-specific findings of the landmark clinical trials of HFrEF and HFpEF. And before I leave you, I want to just end with one final thank you slide, telling you about a book that I've recently published called Mastering the Art of Patient Care that includes many of these lessons and others. You can go to Springer, search the title, and order one for yourself and one for your favorite trainee. Thank you so much for your attention. It's really been an honor to speak at this symposium.
John, over to you for your comments.
Well, I happen to agree with Michelle's perspective on that. One of the things that I've always found the CRT data very interesting. And one of the things I've been wondering if somebody can look at is that different, is the relationship between the shorter CRT interval being effective in women a function of the smaller ventricular sizes, such that smaller ventricles are more susceptible to even less severe dyssynchrony. And so I'm wondering whether it's actually a sex difference or whether it's a baseline substrate difference in terms of the CRT. But otherwise, I agree with the proposal as there. I think right now we need to give the 4 pillars to the patients with HFrEF. There is intriguing evidence in terms of the ARNIs for HFpEF. And I think that, otherwise I agree with her statements. I'm interested to hear what other people think.
No, we agree with that. I think all of us feel that the therapies need to be applied equally with the available evidence. So John, finally, it's your turn. Optimizing treatment for hospitalized heart failure patients. What, when, and how?
So I am keeping people from lunch, obviously, I think, probably. So my apologies. We'll see how quickly I can get through this. It's once again a great opportunity to kind of complete this session and fantastic opportunity to be speaking at this meeting. These once again are still my disclosures. And obviously, heart failure hospitalizations are a huge problem. These are data from the United States showing that it's been progressively increasing during the last few years. In addition, when you look at data from southern India, you see that these heart failure hospitalizations have long durations of index hospitalization and very high in-hospital mortality. The in-hospital mortality in this sample of 1,200 patients is 8.5%. So that is above the risk of somebody with advanced atherosclerotic disease just occurring in that 6-day period. So it's a very important issue. So I've been asked to talk about what are the treatments for hospitalized heart failure patients, when should these treatments be initiated, and how should these treatments be administered. So starting with what treatments for hospitalized heart failure patients, I'm going to limit my discussion to medical therapy because the device therapy is a completely other group of therapies. And these are data from the Cardiologic Society of India, treatment of hospitalized heart failure. And you can see that they recommend inotropes, diuretics, and vasodilators. And interestingly, when you look at the state of the art from the ESC guidelines, the recommendation is IV loop diuretics, sometimes IV loop diuretics with thiazides, vasodilators, inotropic agents, and a vasopressor, preferably norepinephrine. Not surprisingly, the US guidelines say the exact boring thing that's been the same for over 3 decades now. You can use intravenous loop diuretics. You can add another diuretic if you're not having the appropriate response. You can use nitroglycerin or nitroprusside for symptom improvement, and you can give intravenous inotropic and vasopressor support if necessary. So we really haven't had much, despite what we've seen in chronic heart failure, we've had very minimal advances in acute heart failure. A more recent publication by Wilfred Mullins in New England Journal, the ADVOR trial, enrolled 519 patients with acute heart failure and volume overload, elevated natriuretic peptides, randomized them to receive acetazolamide or placebo, in addition to the standardized IV loop diuretics. And I will assert that the standardized IV loop diuretic that they used in this trial was hugely insufficient. And these patients were at baseline markedly inadequately treated. And so, yes, adding another diuretic on top of inadequate baseline diuretics, there was an improvement in successful decongestion, there was a reduction in the congestion score, and there was a reduction in successful decongestion at discharge. But also, and these are all related in terms of these beneficial effects, they had a decrease in hospital stay. So decreasing congestion is clearly important and is effective as you use a more aggressive diuretic regimen. Interestingly, though, there was no difference, and if anything, an increase in death from any cause or hospitalization for heart failure, as we saw in this trial when viewed out to 3 months. So while this initial decongestion was very helpful, it had no beneficial effect on long-term outcomes. Another approach is the vasodilator. So this is the galactic, not galactic HF, this is the galactic vasodilator trial, enrolled 788 patients. Once again, acute heart failure, dyspnea, increased natriuretic peptides, blood pressures above 100, and a plan for non-ICU care. Patients were treated very aggressively early on with nitrates and hydralazine, and then followed by rapid ACE, ARB, or ARNI uptitration. And as you can see on the figure on the right, there was no benefit in terms of this early initiation of vasodilator therapy. In addition, we have the long history of the failure of the calcitropic agents that improve cardiac function by increasing calcium in the heart. And these agents are reserved for our end-stage therapies where we have to use them. In other settings, I would ask people to raise their hand if they recognize that these agents increase mortality, increase arrhythmias, and increase myocardial oxygen demand. Almost everybody raises their hand. And then I say, okay, how many of you use these agents? And almost everybody raises their hand. This is what we have to deal with because we don't have any good alternatives yet. So what are the goals of this acute heart failure therapy? Well, primarily it's going to be decongestion and then maintaining perfusion. And I would assert that protecting against end organ dysfunction is important. And then also facilitating the initiation or uptitration of GDMT and hopefully improve long-term outcomes. I've already talked about omecamtiv mecarbil in my first discussion. And as I mentioned, this increases the cardiac function by improving the myosin-actin interaction. And in the atomic AHF trial that I referred to during our discussion period, we gave omecamtiv mecarbil to patients with acute heart failure and reduced ejection fraction, and saw that in the patients in cohort 3 that had the plasma concentrations of the level that we used in the clinical trials, they had a significant improvement in dyspnea. So this is one potential mechanism for improving function. What about another potential mechanism? Well, istaroxime, as I mentioned in my prior talk, is a very interesting intravenous agent that can improve both systolic contraction and diastolic relaxation and the filling function of the heart. And in a most recent publication, the SEISMIC trial, which is a 60-patient trial, hospitalized for acute heart failure with SCAI stage B pre-cardiogenic shock, and you can see the criterion there listed on the left, EFs less than 40% with persistent hypotension in the absence of any evidence of marked hypoperfusion, they are randomized to istaroxime and placebo. The primary endpoint was an improvement in systolic blood pressure. And interestingly, this primary endpoint was significantly met with the infusion of istaroxime, where istaroxime resulted in a significant increase in the systolic blood pressure during the course of the intravenous therapy. So this represents another potential new therapy that might actually make its way to our therapeutic armamentarium in acute heart failure. Then third, there's another interesting approach, and this is serelaxin, which is recombinant relaxin. Relaxin has it's a naturally occurring human hormone that has multiple potentially beneficial effects in the setting of acute heart failure, including decreasing myocardial overload, improving renal function, decreasing extracellular matrix remodeling, and improving cellular preservation. As you may recall, the RELAX-HF2 trial enrolled over 6,000 patients hospitalized for acute heart failure, randomized to serelaxin or placebo, and treated within 16 hours of hitting the door, and could be given standard therapy. The primary endpoint was cardiovascular mortality through day 180, which was not met, and worsening heart failure through day 5, which was borderline, was not met either. Interestingly, and this is something we saw both in the RELAX-HF and RELAX-HF2 trials, in both of these trials, and unique to any acute heart failure medication, there was a significant improvement in troponin T, with evidence of cardiac protection by serelaxin in this acute heart failure setting, in addition to renal protection and liver protection. So this is a potential interesting direction and is being pursued by multiple other programs. When you look at the overall serelaxin development program with over 11,000 patients in this overall program, there is a highly significant reduction in the worsening of heart failure to day 5, as well as actually a nominal decrease in all-cause death. So these are very intriguing findings, and I think suggesting that maybe serelaxin and perhaps longer-term administration of serelaxin may be advantageous. So when should these treatments be initiated? The ESC guidelines have a very nice structure here of immediate phase and intermediate phase and pre-discharge and long-term phase. I've been focusing mostly on the immediate phase because the intermediate phases and pre-discharge and long-term phases all relate back to what you've been hearing all day in terms of guideline-directed medical therapy. The question is, when should we start? Well, if you look at the Soloist WHF trial, these patients with 1,200 or so patients, all of whom had type 2 diabetes, and then were also recently hospitalized for worsening heart failure, were randomized to sotagliflozin and placebo. About half of the patients were first dose were administered pre-discharge, and then half of the patients were administered post-discharge. So this is really not during the heart failure hospitalization, but immediately around the discharge point. And as we've already seen, there's this 33% reduction in the overall event rate, the hazard ratio for the cardiovascular deaths and hospitalizations and urgent visits for heart failure. So clearly, the SGLT2 inhibitor can be started at discharge. Well, then we also have the AFFIRM-AHF trial that Professor Anker was very involved with. We had 1,132 patients randomized with acute heart failure and iron deficiency, EFs less than 50%, and given intravenous ferric carboxymaltose or placebo. And in these patients where we had pre-discharge administration, while there's some debate in terms of interpreting the statistical numbers of these, there's clearly a suggestion of a beneficial effect of this therapy being given pre-discharge. So now we have pre-discharge beneficial effects. What about pre-discharge initiation of the ARNI? So we have the PIONEER study. On the left-hand panel, you have the original New England Journal of Medicine article with the 881 patients admitted for acute decompensated heart failure, an EF less than 40%, elevated natriuretic peptides, randomized to sacubitril valsartan or enalapril. And these were initiated after stabilization, where the primary endpoint was a reduction in NT-proBNP. And this primary endpoint was met by the figure that's on the left-hand side. Interestingly, and this was presented by David Moreau in the Circulation article, there was also a significant reduction in the cumulative incidence of cardiovascular death or rehospitalization for heart failure. So now the pre-discharge initiation of an ARNI is now demonstrating a beneficial effect. Then what about actually if you move in earlier in the hospital course? And so in the MPulse trial, there were 530 patients with a primary diagnosis of acute de novo or decompensated heart failure, regardless of EF, regardless of diabetes, randomized to empagliflozin or placebo, randomized in hospital within 1 to 5 days from admission, and the benefit being the win ratio that was previously described, where there was a 54% of the patients treated with EMPA had beneficial clinical benefit, compared to only 40% of the patients who were on placebo. Interestingly, when you looked actually at the more standard endpoint of cardiovascular all-cause mortality or heart failure events, you had a 35% reduction in this endpoint overall, with a number needed to treat of 15 patients for 90 days to prevent an event. This is a remarkable beneficial effect. And now this is moving our GDMT to, as soon as the patient stabilized in hospital, you should initiate these therapies. So how should these therapies be administered? Beacon Boskurt did a very nice description of this in one of her editorials, where the initial target is clearly symptoms of congestion, signs of congestion, the elevated natriuretic peptides, and filling pressures. And you can evaluate these as seen on the table on the right-hand side, listing the potential things to monitor. There are clinical trials that have used endpoints of successful decongestion listed on the bottom. And one of the suggestions that's already been alluded to is in the ESC guidelines, using urinary spot sodiums to help guide diuretic therapy. So that's one approach to trying to maximize the decongestion of the patient. Another approach is to do lung ultrasound. This is the blushed AHF, a pilot study of using lung ultrasound in 130 patients. The patients were randomized with acute heart failure, dyspnea, chest x-ray evidence of acute heart failure, as well as at least 15 B lines on their lung ultrasound. The primary endpoint was B lines reduced, the proportion B lines less than or equal to 15 at 6 hours. That was not statistically met, but there was a marked decrease in the lung B lines consistent with decreased decongestion when using this method to track patients. Then finally, and this is the important thing that we've heard a lot about during this meeting, the other approach is to just get these agents on board very early. So we have the strong HF program that had this enrolling patients with acute heart failure, about 1,800 patients randomized to either usual care or high intensity care. The high intensity care included introduction of half optimal doses of heart failure therapy during the hospitalization, and then follow-up visits at week 1, 2, 3, and 6. So I can't tell you what the beneficial effect is here, whether it's the frequent follow-up, whether it's the early initiation of therapy, whether it's being cared for by cardiologists as opposed to just general physicians. But whatever it was, strong HF had a dramatic benefit. The primary endpoint was reduced with a 8.1% absolute risk difference compared between high intensity care and usual care, and a significant reduction in the all-cause death with a risk difference of 1.6. So this was a very important trial and that kind of shows us that these kind of early interventions can be beneficial. My apologies, it did not reach its statistical significance in terms of the all-cause death. So there are multiple directions in terms of our treatment of heart failure hospitalized patients. And I look forward to have a little discussion if we have it before you folks go and eat your lunch. Thanks very much for your attention.
Thank you, John, for telling us what we should use, what we should not use, and how we should be using that. So, Stephen?
Well, I completely agree with the main point here. The hospital is the place to start making a difference. And that's where the patient is receptive to change. That's where the patient sees the experts. And that's where then also, I believe, we can initiate and trigger subsequent changes that hopefully in the ambulatory setting, whether done by the same patients, physicians, or done by other physicians, can be initiated. The hospital is the key place.
So with that, I think we come to the end of this very interesting session, and I'd like to thank John and his colleagues for their presentations. And John, hopefully see you next year in person.
Next year in Delhi, right? New Delhi?
Yes, New Delhi. So we close this session, and next there's a interesting session. We have a recently formed association with the Asian Heart Society, and in that Dr. Harikrishnan has been elected as chair for heart failure section. So we have a session with Asian Heart Failure Society. The talks are online, but the panel discussion will be live. So can we have the, yeah. Okay, right. Yeah. So is Dr. Mrinal Kanti Das here for the introduction? Dr. Das? Where? Yeah, hello, welcome, Dr.
Yes.
Das.
Yeah.
So
Good,
we have.
good afternoon, everyone.
Good afternoon. Can we have a brief introduction so that we finish in time? So over to you, Dr. Das.
Okay.
Dr.
Uh,
Das.
Welcome to this joint session. Oh, Dr. Ma is there. Welcome to this joint session of Heart Failure Association of India and this Asian Heart Society. In fact, the heart failure is a growing problem, and almost 64 million people are attacked over the world, and almost 0.3% of the population in India and 1.5 to 2% population of China are getting affected with this disease. Now, already so many points have been discussed so far. The therapeutic aspects are concerned, especially the 4 pillars of the heart failure therapy, that is the ACE or inhibitor or ARNI or beta blocker, then MRA antagonist, and also SGLT2 inhibitors. And most of the things have been discussed in detail. And there have been wide range of left ventricular ejection fraction phenomenon, which has the which is a pointer to the various therapeutic measures. And I think the discussion that will be following on in a few minutes from now will be depicting many of these problems, as well as the newer problems and newer therapeutic measures that can be there. And I am really thankful to the Heart Failure Association of India, and on behalf of the Asian Heart Society, I really thank the organizers for giving us the opportunity to have this joint session. Over to Dr. Hari Krishnan and Dr. Chopra.
Thank you, Dr. Das. And we have a message from Dr. Ma. Dr. Ma, can we have your message, please?
Good afternoon, dear President Dr. Das, dear Councillor Dr. Hari Krishnan, and dear AHS colleagues and Hfai colleagues. This is Dr. Changsheng Ma from Asian Heart Society. It's my great pleasure to attend the Hfai AHS joint webinar today. Last year, we officially launched the Asian Heart Society. Once again, I would like to express my sincere thanks to AHS founding members and everyone's hard work. Our AHS founding members and Asian colleagues work in 8 councils based on different subspecialties. Today's heart failure webinar is one of our starting webinars of this year's AHS scientific activities, which truly made a milestone in the development of AHS. Asia is the largest and the most populous continent. Over the past 50 years, Asia's growth and development was built on significant advances in technology. Nowadays, scientific studies and research are booming, especially heart failure studies focusing on the Asian population. Our Asian colleagues focusing on heart failure field have a chance to exchange our new ideas in the webinars and to exchange our experiences to focus on the Asian population. Under the leadership of Professor Das and Professor Hari Krishnan, the AHS Heart Failure Council will surely have a bright future. I have great faith in AHS and our Asian colleagues. I believe that this joint session will be a great success. I hope that we can meet each other in person in near future. Thank you.
Thank you, Dr. Ma. And now may I invite Dr. Hari Krishnan for his talk on heart failure in Asia.
Good afternoon. Can I have the first slide, please? First of all, I thank the Asian Heart Society for this joint session with Heart Failure Association of India. This is a new joint venture. So heart failure, we know the problem. It is a disease with high mortality, as Dr. Stephen Anger was discussing. You know, the mortality of heart failure is higher than many common cancers like breast or colon. I will discuss the long-term mortality in Trivandrum Heart Failure Registry. The 2.2% of the hospital admissions in low middle income countries is due to heart failure. We know the therapy is resource intensive. Significant burden on healthcare resources, because only 2% of the Western world health resources is channeled towards heart failure management. We know that there is a significant loss of productivity and there is a significant impact on economy. What is the burden of heart failure in Asia? There is some data from the Chinese study. 1.3% of they have estimated 13.7 million of heart failure patients in China. There is real data on incidence on prevalence for the other regions, other countries in the region. So if you estimate the 50% of US prevalence, that is 1% to the Asian population of 282 crore patients, it will be 28 million, 2.8 crores. So what we will see, what will be the projected burden, because we know that as age advances, heart failure prevalence increases. So this is the population of India, 60 plus in 2011 and the projected figure in 2051. From 8% it is going to be 21%. Naturally, the prevalence of heart failure is going to rise exponentially. The prevalence of diabetes, we know that the prevalence of diabetes is increasing. In Kerala it is around 20%. In some parts of India like Punjab, Tamil Nadu also the prevalence is very high. China is also having a high prevalence of diabetes. Hypertension, we know that it is significantly increased over the last 3 decades. Obesity, India and China are next only to US in the number of obese people. Coronary artery disease prevalence, the age-adjusted prevalence is very high in many Asian countries, including India. We know that ischemic heart disease occur in India at a lesser, younger age. This is the data from the CREATE and the Kerala ACS, where the age was around 57 to 60, where the US NRMI data is 68. There's a rise in coronary artery disease prevalence. This is a study which we have done in Trivandrum with in a 23 years gap. The first study was done in 1993. Subsequently, it was the same population was studied in 2016. The prevalence was 1.4. It increased to 3.5. There's a 250% increase in the 23 years of assessment. Some data on all diseases. Rheumatic heart disease is still prevalent in Asian countries. As you see, the larger dots are in the Asian countries and Africa. Congenital heart disease, still the untreated congenital heart disease is a major problem. And many of the diagnosis is missed, and many patients will go on to untreatable pulmonary hypertension, even though they can be salvaged early in life. Then there are some etiologies more common in the Asian region, like the emergent infectious disease epidemics like leptospirosis, where 4% had heart failure. Dengue fever, the recent study from Trivandrum, 13% had EF less than 40%. COVID-19, we know significant burden on cardiovascular disease. Then pulmonary hypertension due to COPD because of the biomass fuel use in India. Then pulmonary hypertension due to various etiologies like schistosomiasis, infective endocarditis, peripartum cardiomyopathy, anemia which can complicate or worsen heart failure, rare cardiomyopathies like endomyocardial fibrosis in certain regions in India. Now we'll see some of the Indian data. This is the data from the National Heart Failure Registry which we published last year, 10,851 patients, the largest heart failure registry from India, which we coordinated. The main findings were the patients were younger by 10 years and the male-female ratio was 70-30. In the Western world it is 50-50. Here it is 70-30. You can see the age group, it is around 60. You can see even the Chinese data, it is around 70 plus. So our patients Indian patients are 10 to 15 years younger compared to the patients outside the country. This sex ratio we already discussed, 70-30 in the Asian population compared to 50-50 in the Western world. This is a very interesting data. You can see the proportion of heart failure with reduced ejection fraction. 2/3 of our patients are having reduced ejection fraction. You can see the preserved ejection fraction is very low, 12 to 15% only. In the Western world, it is 50-50. Preserved ejection fraction is almost the same as reduced ejection fraction. But we have a single peak of EF. If you plot the EF, you can see this is a single peak. In the US, you can see it is the Western data, it is a bimodal peak. But interestingly, the Chinese data is significantly different. Heart failure with reduced ejection fraction is only 35, preserved ejection fraction is 43. So it is significantly different. So there is a significant wide variation between different countries in the Asian region. That is also very important. Coming to the etiology, you can see ischemic heart disease contributes to 3/4 of the burden in India, dilated cardiomyopathy and rheumatic heart disease. These three major contributors contribute to around 95% of the burden of heart failure in India. Ischemic heart disease, dilated cardiomyopathy and rheumatic heart disease. This is a profile of the population from Malaysia. It is almost similar, exactly similar to what the Indian data is. But the Chinese data is significantly different, as we have seen. This is the etiology of different countries in the region, significantly different. So there is a wide variation of the etiologies in different regions in Asia. So basically this is the data compilation of rest of Asia versus India. Age distribution is lower in Middle East and India. More males in India, Japan and Middle East. Prevalence of CAD is highest in of coronary artery disease was highest in the Indian population. And device implantation was uniformly low in the whole of the population. All the Indian registers, it was 2%, while some of the Netherlands data, 45% of patients with a low ejection fraction are having a device. So heart failure in Asia, we can say that the burden is likely to be high, expected to rise in the near future if the current trends continue, due to the rise in the prevalence of risk factors and persistence of old age diseases. This is what we call as a double burden of heart failure. But there is a significant variation within this region. Coming to guideline directed therapy, this is from our data, because this data was collected before the introduction of SGLT2 inhibitors as the fourth pillar. We can see that the combination of ACE-ARB plus beta blocker plus mineralocorticoid receptor antagonist was given in an eligible population, only in 47% of eligible population. So there is a significant scope of improvement of the guideline directed therapy. What is the in-hospital mortality? Significantly higher. This is the data from Indian, the Trivandrum registry and the national registry. It is around 3.8 to 5.5 in the Western data, Europe and USA. Our in-hospital mortality is higher, probably because they reach late. Ischemic heart disease is the most common cause. They reach late. Our the presentation to hospital door time is significantly higher in India. So what about guideline directed therapy? Does it make a significant difference? They make a significant difference. You can see that very significant difference of mortality in patients who receive guideline directed therapy in India. So you should prescribe guideline directed therapy in patients, and the mid-range ejection fraction patients also benefit significantly with guideline directed therapy. Affordability of care is very, very important, because we know that heart failure therapy is resource intensive, ICU care, costly therapy, lifelong treatment. And the device therapy, for example, 2% of the patients received devices, as we have seen, because mainly they spent out of pocket. Because the new schemes like Ayushman Bharat may make a difference that we have to see. What is the long-term mortality? This is the data from the Trivandrum Heart Failure Registry, which you are following 1,200 patients. Now we have almost an 8-year of follow-up. The 1-year mortality was 30%, 3-year mortality was 45%, and 5-year mortality was 58%. We have the 7-year mortality, it is nearly 68%. So almost we are losing at 7 years, almost 75, 3/4 of the patients we are losing due to heart failure. So this is a mortality trend, 30, 45 and 60, it's easy to remember. So there is this is the data from the Asian Heart Failure Registry. You can see there's a significant variation in different countries. They have divided into Northeast Asia, South Asia and Southeast Asia. There's a significant difference where the Northeast Asia had a significantly higher mortality compared to other regions. So if you assess the problems of heart failure, we can say that it is due to accessibility, availability and affordability issues, because Asia has an uneven and limited access to healthcare. Remote villages, highlands, islands, etc., the limited access, overloaded public healthcare system which is already stressed, and emergency medical services are not available, not universally available, because as I said, the door to balloon time is significantly higher. So huge burden on the healthcare system, burden is probably on the rise. So our aim should be to prevent heart failure rather than treat it by initiating primary and secondary prevention initiatives. What can be done? Early detection and treatment of hypertension and diabetes. You have to start in the very young age in the schools. You have to include it in the curriculum about diseases like hypertension, diabetes. All those things you have to cultivate the habits of healthy eating, regular physical activity. All those things should be treated in colleges and schools. A primary PCI should be the time to reach the hospitals. The patients has to be educated for the early benefit of early treatment, and pulse oximeter screening of newborns. Penicillin prophylaxis for secondary prevention of rheumatic heart disease, and early diagnosis and referral of pulmonary hypertension. So to conclude, ladies and gentlemen, heart failure in Asia, the profile of patients within Asian region varies but has many similarities. Guideline directed therapy is underutilized but very, very beneficial. Accessibility, availability and affordability issues affect the management, and for us, prevention of heart failure is the key. Thank you.
Thank you, Dr. Hari Krishnan, for very accurately summarizing what is happening. So I think the key words are accessibility, affordability, and availability. And also, even in the Trivandrum Heart Failure Registry analysis, we saw that those who received good therapy, guideline-directed therapy, their outcomes were much better than those who did not. So with that, now we go on to the next presentation by Dr. Dong, who's going to tell us about the causality of left bundle branch block and congestive heart failure. Dr. Dong.
Thank you. Thank you. I have recorded that. Okay.
Yeah, Dr. Dong, we will. Hello. Can you?
Dear Chairman, dear colleagues, congratulations to Hfai 2023. I'm Dr. Dong from Beijing. Today I'll talk about causality of left bundle branch block and heart failure with reduced ejection fraction. Left bundle branch block is common. This study showed that the incidence of left bundle branch block will increase with the age increasing. This is our study in China. This is a cross-sectional study demonstrate that the prevalence of left bundle branch block is 0.17% in people older than 35 years old. The left bundle branch block is more common in patients with heart failure. The two studies demonstrated that the prevalence of left bundle branch block is 20% in people in HFrEF patients younger than 65 years old, but it's 28% in HFrEF patients older than 80 years old. And the prevalence of left bundle branch block increase greatly, fastly. Left bundle branch block is an independent predictor of cardiovascular outcomes. It increases the risk of heart failure by 3.77-fold. Half-RIF patients with left bundle branch block has a very effective, well-accepted treatment of cardiac resynchronization therapy. In short, CRT. CRT is class 1 or class 2A recommendation for half-REF patients with complete left bundle branch block. But only 2/3 patients response to CRT treatment, and 1/3 patients don't respond to CRT treatment. Why some patients respond well to CRT treatment, some patients don't respond to CRT treatment? This is a very important question for CRT treatment of patients, half-REF patients with left bundle branch block. The studies demonstrated that many factors associated with the response rate of CRT treatment. But the most important is the causal relationship between left bundle branch blocker and heart RIF. If left bundle branch block comes faster and result in half-REF, it's primary left bundle branch block. Usually, we told we have a name of left bundle branch blocker cardiomyopathy. If left bundle branch blocker secondary to half-REF, means left bundle branch blocker comes after half-REF. I have a name, secondary left bundle branch blocker. It's true cardiomyopathy or primary cardiomyopathy. How to determine the causal relationship between left bundle branch block and half-REF? The first method is the response to resynchronization therapy. If the patient responds well to resynchronization therapy, it's primary left bundle branch block or left bundle branch block cardiomyopathy. If the patient doesn't respond to resynchronization therapy, is secondary left bundle branch block or primary dilated cardiomyopathy. But by this method, we cannot know, we can evaluate it after resynchronization therapy. In clinically important thing is we should know who responds well to resynchronization therapy before the treatment. So the most important is the time sequence, chronological sequence, time sequence of the onset of left bundle branch blocker and half-REF. If left bundle branch block comes firstly, it's primary left bundle branch block. If left bundle branch block comes secondly to half-REF, it's secondary left bundle branch block. Left bundle branch block cardiomyopathy was first proposed in 2005. The 5 half-REF patients with left bundle branch block recovered both structurally and functionally 1 year after resynchronization therapy. It's primary left bundle branch block. Thus, another study reported 375 half-ref patients with left bundle branch block treated by resynchronization therapy. In the close to 400 patients, only 6 patients, we can only know the time sequence of left bundle branch block and heart failure for 6 patients. It's left bundle branch block comes faster with normal baseline ejection fraction. That's the 6 patients is left bundle branch block cardiomyopathy or primary left bundle branch block. And the 5 patients response to resynchronization very well. So according to the time sequence, we can only know the relationship between LBBB and cardiomyopathy in very, very few patients. So we cannot determine the relationship between LBBB and half-ref by the time sequencing of left bundle branch block and cardiomyopathy. Of course, with the electrical system progress, maybe in the future, many patients will know the time sequence. Normal heart contraction, normal heart output depends on the normal His-Purkinje system, age, the very determinants of ventricular synchronization. If left bundle branch block occurred, the left ventricle will activated from septal to the lateral through the slowly conduction over the myocardium. So when in patients with left bundle branch block, the septal excited and contract forcefully, and the lateral contraction laterally. In patients with left bundle branch block, the septal excited contract forcefully, which cannot open the aortic valve. So the septal wall contraction doesn't contribute to the cardiac output, doesn't work. And the lateral wall contributed to the whole cardiac output. So the septal wall doesn't work and gradually will get atrophy. This is a very wise study in patients with DDD pacemaker because of sick sinus syndrome. When they do ventricular pacing, the left ventricular ejection fraction will decrease faster, and after return to normal sinus pacing, normal supraventricular rhythm, the left ventricular ejection come to normal gradually. It proved that the desynchronization of left ventricle will destroy the cardiac output. Thus, a study, CAT study, cut the papillary and the cardiomyocyte area will decrease gradually. And when the the sew together, the cardiomyocyte will recover gradually. That's another study, animal study, when pacing at the inferior lateral wall, and after pacing, the pacing site will get thinner and thinner, but the contralateral wall is very thick, very thick, because of the pacing site, the myocardium contraction early, it don't contribute to cardiac output and get atrophy. For patients with left bundle branch block resulting in heart failure, very easy to understand because of desynchronization. In fact, it's has a very interesting inside mechanism. In patients with left bundle branch block, septal wall work first, contraction first doesn't work, and gradually it will get atrophy. And the whole cardiac output mainly contribution by the lateral wall. And lateral wall contraction lately, it will push the septal wall to the right ventricle. That's paradoxical moment. Of course, resynchronization therapy is very important for patients with left bundle branch block. That's my patients with left bundle branch block. You can see the perfusion imaging showed that the significant deficiency at the septal wall, like a anterior septal myocardial infarction. In fact, there is no fibrosis. It's because of the septal wall atrophy, kinesis, thinner and kinesis. So the perfusion decreased fastly. This from a patient with left bundle branch block, we can see the desynchronization by naked eye. The septal wall during systole, the septal wall doesn't thicken, but the thickening is more and more significant from septal to the lateral wall. So for patients, half-life patients with left bundle branch block, if bundle branch block may be primarily or secondary. If the left bundle branch block is primary, the patient is characterized by the thickening gradually better from septal wall to the lateral wall. But for secondary left bundle branch block, the whole heart should be seen, and the thickening is also bad at the lateral wall. That's my hypothesis. In order to answer the question, to prove my hypothesis, we collect patients from my hospital for patients with left bundle branch block, half-life, and cardiac myocardium resonance imaging study. We get 150 patients fulfill these criteria. and after excluding hypertrophic cardiomyopathy, valvular disease, myocardial infarction, 33 patients left. And then we try our best to collect the past history to evaluate the time sequence between left bundle branch block and Hfai. Finally, we clearly know the time sequence in 14 patients. 7 patients are primary left bundle. 7 patients are primary left bundle branch block, and 7 patients are secondary left boundary block. This is the thickness ratio between the lateral wall and the septal wall. Lateral wall and the diastatic lateral and the septal wall thickness ratio. In primary left bundle branch blocker, the average ratio is 1.04. In secondary left bundle branch blocker, the average ratio is 0.77. There's no overlap between the two groups. The second important characteristic is the thickening rate of lateral wall. In patients with secondary left bundle branch block, the lateral wall thickening rate is very low. The average thickening rate is 11.04, and in primary left bundle branch block, the lateral wall thickening rate is 30.85%. It's far different between the two groups. This strain is also far different between primary left bundle branch block and secondary branch block. The spore eye picture of the left wall thickening in patients with primary left bundle branch block, the left vertical wall thickening get better and better from septal to lateral wall. The lateral wall is with preserved normal thickening, but in patients with secondary left bundle branch block, the thickening at the lateral wall is also very low. Is very low. This is a patient, Hfai patient with primary left bundle branch block. We can see the preserved thickening of left wall. The thickening is better from septal to lateral. It's gradually get better and better from septal to lateral wall. But for patients with secondary left bundle branch block, the left wall thickening is bad, is also bad. With the two characteristics, lateral wall thickening rate and end-diastolic lateral wall to septal wall thickness ratio, the 63 patients were classified into distinct two groups. One group is like a primary left bundle branch block. Another group is secondary left bundle branch block. or concept also proved by the publication from Europe last year. If patients with preserved left ventricular contraction, the patient will respond well to resynchronization therapy. Ladies and gentlemen, that's my last slide. In patients with HFrEF and left bundle branch block consists of two different scenarios. It's primary left bundle branch block and secondary left bundle branch block. In patients with HFrEF and left bundle branch block, more than half meet the characteristics of primary left bundle branch block. These patients will respond well to cardiac resynchronization therapy. Only by medical history, the causal relationship between left bundle branch block and HFrEF can be determined in a few patients. Gradually preserved thickness and the thickening of the lateral wall is the specific characteristics of primary left bundle branch block. Otherwise, it's secondary left bundle branch block. Of course, the patients with primary left bundle branch block will respond well to cardiac resynchronization therapy. If the patients with secondary left bundle branch block will not respond well to cardiac resynchronization therapy. I'll stop there. Thanks for your attention.
Thank you, Dr. Dong. Dr. Belbir, are you there?
Yes, I'm there.
Any comments on the talk? Yeah.
So very interesting talk. We have to understand that there are two different patients. One who has left bundle branch block and he progresses to heart failure. There is another one who presents with heart failure and has left bundle branch block. It becomes very difficult to distinguish in such a patient whether the electrical problem caused a mechanical problem or heart failure. But it is clear LBB in itself is a disease. For physicians, if a patient comes with LBB, normal LV ejection fraction, they should get an echo every year. They should get a strain imaging, and sometimes even an MRI can help to understand whether this patient is a higher chance of getting into heart failure or not. And this is the beginning of a patient. So in our institute, if a patient comes with LBB and syncope, we go for a his bundle or a left bundle pacing, even if his ejection fraction is normal, because we are wary of the fact that this patient can later on get into heart failure. Similarly, a patient who has left bundle branch block and has mid-range ejection fraction and comes with syncope, he gets a CRT because he's going to progress. Even though his ejection fraction may be between 40 and 45, it is going to progress a little later. So one has to be very careful about this LBB and intervening with such patients.
Thank you, Dr. Belbir. I think due to lack of time, we will move forward. Thank you, Dr. Dong, for joining us. And we will, before moving to the talk by Dr. Sun, we have Dr. B.K. Shastri, who will briefly, because he has to leave for his flight. So brief comment.
Quick comment. Professor Dong, wonderful talk. Thank you very much. The primary LBBB cardiomyopathy that you described, in addition to that, we see two kinds of patients who have got rate-dependent left bundle branch block. Over a period of time, the rate at which the left bundle branch block, as the age advances, it comes down. Initially, the left bundle branch block appears at, say, 110, 120 beats per minute. As the time goes on, LBBB starts appearing at even 60, 70 years of age. That is one subset. The second subset, which has been described in the literature, patients with classical angina with normal coronaries, what we call syndrome X, some of them over a period of years develop left bundle branch block. Do the patients that you describe belong to any of these categories, or they are different?
Of course, there should be one scenario between between primary left bundle branch blocker and the secondary bundle branch blocker. But my data showed that my 63 patients are classified in two separate groups. Myocardial infarction are excluded in my study.
Okay, thank you. Shall we move to the next talk by Dr. Yihong Sun on pulmonary hypertension and heart failure? Can we have the presentation, please?
Dear Chairman and dear colleagues, I'm Dr. Yihong Sun from China, and I'm very pleased to have this opportunity to join this very important symposium related to heart failure. So my topic today is about the pulmonary hypertension related to the left heart disease, especially left heart failure. So I'm from the China-Japan Francis Hospital based in Beijing. Let's start from the clinical classification of the pulmonary hypertension. So all of us are very familiar with this WHO criteria for the classification of PH. So what we are talking about today is the type 2 pulmonary hypertension, so-called the pulmonary hypertension due to the left heart disease. And most of the left heart disease lead to the pulmonary hypertension are heart failure with preserved ejection fraction and heart failure with a reduced ejection fraction, as well a number of patients who suffered from the very significant valvular heart disease is one of the common left heart disease as well. And so this is the classic clinical classification. So another classification, or we call it the hemodynamic category of pulmonary hypertension, is post-capillary pulmonary hypertension and the pre-capillary pulmonary hypertension. So these two kind of pulmonary hypertension is very different according to the underlying heart dysfunction, the underlying heart disease, and pulmonary hemodynamics. So we all know that most of the left heart disease will lead to the post-capillary pulmonary hypertension at first stage, and in some advanced left heart disease that we will talking in my lecture is to talk about patients who developed to the combined hypertension, so-called combined post-capillary and pre-capillary hypertension. So that's a very important phenomenon, because whenever the patients suffer from this combined pulmonary hypertension, it indicates a very poor prognosis and a very poor cardiac function as well. So we'll be talking about the pulmonary hypertension in patients with left heart disease. I think this is first recognized in the patients with mitral stenosis. So this is a very old paper to show that the pathophysiology of the pulmonary circulation in patients with mitral stenosis. It showed from the picture from A to D to show the different stage of the pulmonary circulation and dysfunction. And in 1945, the Dr. Cornard performed the first right heart catheter in patients with very severe mitral stenosis, and he found that the very late systolic pulmonary artery pressure curve was the features of this advanced pulmonary viral disease, and it indicated a very significant increase in the right ventricular afterload. And from the autopsy of this pulmonary artery, we can say the medial hypertrophy within intimal and one share of the proliferation in the artery. This is first indicated that for patients with left heart disease, we can suffer the pulmonary hypertension due to the pathophysiology deterioration of the pulmonary artery. So some recent data regarding the pathophysiology of patients with heart failure and pulmonary hypertension, we can see this data published in Circulation from the Mayo Clinic. In this study, about 200 patients have the autopsy of the pulmonary circulation, including venous and pulmonary and artery as well. So we can see from this chart, it shows that especially for patients with Hfai, this means that the patients with preserved ejection fraction, the pathophysiology changes of the pulmonary vessels is very similar to the PVOD. PVOD is a disease that we call the pulmonary vein occlusive disease. So it is a very severe disease that can cause pulmonary hypertension, and the main dysfunction is the venous, the pulmonary venous. So pulmonary hypertension is associated with global pulmonary vascular remodeling for all the patients with Hfai and Hfref. But the severity of this hypertension correlated most strongly with the venous and a small indeterminate vascular initial thickness, very similar to the patterns we observed in the PVOD patients. So this is some picture from this autopsy to show the initial and washer proliferation of this different kind of disease. So what is very important for the patients with hypertension in left heart disease is to separate patients with isolated post-capillary hypertension and to those with combined post and pre hypertension, because for patients with combined post and precapillary hypertension, the hemodynamic change stage is characterized by a mechanical injury and progressive increase in pulmonary vascular resistance and also the mean pulmonary artery pressure. So this phenomenon first protects against the fluid swelling, but this also will compress gas exchange diffusion for patients with heart failure. So the venous system become very fully arterialized, and some arteries exhibit a clear vascularization process and remodeling. And this also have other very important issues related to the choice of this treatment. Besides that, there's also some difference between the patients with Hfai and Hfref if they all have hypertension. For both patients with Hfai and Hfref, the primary hemodynamic driver of hypertension is the impaired left ventricular relaxation and feeding, which yield were transmission of elevated left atrial pressure to the venous system and capillaries and arteries, and ultimately this pressure to the right heart. But the pathophysiology of the left ventricular and the triggers and the cellular phenotypes of this pulmonary artery, there is a very different from Hfai and Hfref. So most generally the patients with Hfref has the ischemic heart disease and dilated heart disease, and have the mitral valve regurgitation and a very large left atrium. On the other hand, the patients with Hfpaf will have hypertrophy and also have more severe pulmonary injury. So what's impact on the PH development in Hfpaf? So I think it's very important for the patients with Hfpaf. The mechanism is very complicated. So most of Hfpaf patients will have hypertension and obese and metabolism dysregulation and COPD. And there are many underlying factors or mediators that will lead to this hypertension for patients with hypertension or obese or COPD. And also there is some investigation or researches to look at the epicardial fat. The accumulation of epicardial fat will lead to the pulmonary hypertension in this kind of patients as well. So how can we to evaluate and treatment this kind of patients? So first we will we'll look at the recommendations from the ESC guideline that's published recently last year. So the prevalence of hypertension in patients with left heart disease is very difficult to assess, and really depends on the methodology for the diagnostic testing. It means that the different diagnosis criteria here between echo and the invasive hemodynamic with the right heart catheterization. So the type 2, the group 2 pulmonary hypertension is have the same definition according to the invasive hemodynamics parameters. It means that the mean pulmonary artery pressure should be above 20 milligrams, and the PAWP is about to 50. If the patients have both these two criteria, we can give the combined pulmonary hypertension as well. So we use the new criteria for pulmonary valvular resistance as at 2 wood for the definition, for the new definition. And advanced heart failure patients, especially with Hfref and Hfpaf and valvular disease patients, can develop the pulmonary hypertension, and pulmonary hypertension itself is associated with increased disease burden and a very worse outcome. So the first step is to evaluate the suspected left heart disease hypertension. So there's 2 steps. The first step is the diagnosis and the control of the underlying left heart disease. It means that you need to surgery for the valvular heart disease, and you need to give PCI for this with ischemic etiology. And the second step is the evaluation of this primary hypertension and the patient phenotyping is isolated post-respiratory hypertension or this combined hypertension, and the invasive assessment of hemodynamics is very important. So generally, we all know that echo is very convenient approach to for the screening of the hypertension, and there are a lot of different parameters in the echo to indicate that maybe the patients maybe have some dysfunction in pulmonary artery circulation, the right heart function. After that, we will differentiate all these patients or separate the patients to find who need invasive evaluation using right heart catheter. So right heart catheter is very important to classify and for the risk stratification for patients with pulmonary hypertension, and it also lead to different treatment strategies. So this is one of the keys of our patients is old female with HFpEF, and we give the patients a right heart catheterization. So this is we evaluated all these parameters at rest and during exercise. So we can see from the data of these patients that during exercise, both the mean pulmonary artery pressure and the PaWT increased significantly, as well as the PVR increased moderately for these patients. So the exercise right heart catheterization is very important for some patients, especially for patients with HFpEF, to unmask some the pulmonary circulation dysfunction. So because if the patients have the was diagnosed as the combined pulmonary hypertension, it indicated that they have lower cardiac output and a higher PCWP and higher mean pulmonary artery pressure, as well as also the indicator of the poor prognosis in the long term. For the last part of this presentation, we were talking about some treatment for the pulmonary hypertension in patients with heart failure. So we all know that SGLT2 inhibitors is the very basic therapies for all the patients with heart failure. And in this brief AF trial, it also shows that the use of the SGLT2 inhibitors also can decrease pulmonary artery pressure compared to the placebo. So how about the medications targeted the pulmonary artery? So there has been a long history for the targeted medication of pulmonary artery to used in the patients with heart failure. So this is the one of the first very typical trials to use the sildenafil. It's a one kind of phosphodiesterase 5 inhibitor for the patients with normal ejection fraction and heart failure with New York Heart Association function class 2 to 5. We all know that this is a negative study, not to show any improvement in the peak oxygen consumption after 24 weeks treatment. So, but there are some small size study after that. This study have conflicting results. If we compare this conflicting results between these trials, we know that the main problem is that not all of these trials will have the hemodynamic criteria for the diagnosis of pulmonary hypertension. If we choose patients with isolated post-capillary hypertension, the targeted medication do not work. But if we choose patients with combined post and pre-capillary hypertension, I think some of the patients do have some benefit regards to the pulmonary artery pressure, and some parameters indicated of the right heart function, the TAPSE, are improved. So there's also indicated that the hemodynamic assessment is very important. How about the endothelium-1 antagonist? There's also some conflicting data, but in this small study, we can say that this macitentan can improve a little bit the anti-BNP level after 12 weeks treatment. And the SGC stimulator, we all know that it is one of the typical targeted medication for type 1 pulmonary hypertension. And in this small study, this phase 2b double-blind randomized placebo-controlled study, it also showed a benefit to decrease the pulmonary vascular resistance, and also increase in the cardiac input index. However, it didn't improve the primary endpoint. The primary endpoint is the mean pulmonary artery pressure. So there are some new investigations and research to using the beta-adrenal agonist. So this is a very classic beta-2 adrenic agonist used for the patient with asthma. So in this small study, so that the albuterol improved exercise, pulmonary vascular resistance, and also enhanced the cardiac output reserve and the right ventricular pulmonary artery coupling compared to the placebo. And the beta-3 adrenic antagonist treatment is under investigation as well. So it also included some patients with pulmonary hypertension, combined pre and post capillary pulmonary hypertension, and to look at if it can reduce the pulmonary vascular resistance as well, because some previous studies, experimental research have showed that the treatment with this beta-3 antagonist can produce some beneficial effects on the hemodynamics and as well as right ventricular remodeling for this group of patients. So for the devices, this is the atrial shunt devices used has been investigated in the Hfai patients. And we all know that the results is not very positive. And the post-hoc analysis of this reduced lab AF2 trial, it shows that if the patients have latent pulmonary vascular disease, so what is the latent pulmonary disease is defined as the exercise PVR about 1.74 volt. For this category of patients, these devices cannot will do harm in this kind of patients. Otherwise, if the patients with very low exercise PVR, they will benefit from this atrial shunt devices. So the hemodynamic assessment is also very important for the patients with heart failure to different the patients who can benefit and can do harm to this kind of treatment. So classification medications is also under investigation as well. So this is my last slide. I will give the summary by using the ESCD-ERS PACE guideline published last year. It shows that there's some big changes compared to the last version. So the red heart catheterization is strongly recommended for patients with suspected pulmonary hypertension in patients with left heart disease. So we all know that the difference between the isolated pulmonary hypertension to the combined pulmonary hypertension is very important, because for patients with combined pre-capillary and post-capillary hypertension, the treatment targeted pulmonary hypertension may be useful for this kind of patient, and it should be the decision making should be made individually. So thank you for your attention.
Thank you very much, Dr. Sun. It's a very interesting talk. You have given insights into the pathophysiology of the pulmonary hypertension, how the pathology evolves, and what are the treatment options, the failure of the pulmonary vasodilators in managing these patients. As you rightly mentioned, classical pulmonary vasodilators, sildenafil, macitentan, have doubtful neutral effect. Probably the ongoing trials with sotatercept and beta-3 agonists may be beneficial. It's really a vexing problem, the pulmonary hypertension, especially due to HFpEF, and also fixed pulmonary hypertension in HFrEF patients waiting for transplant. These are some of the subsets where it's really becoming difficult to treat. Probably the ongoing trials will help us. And the way you demonstrated that the HFpEF pulmonary hypertension pathology resembles more like pulmonary veno-occlusive disease, that explains the difficulty in treating these patients and not much of response to classical pulmonary vasodilators. Thank you very much.
Thank you, Dr. Sun. As demonstrated in the Pro-Kerala registry also, the 54% of the patients were having PH, pulmonary hypertension due to left heart disease. So that is a very major problem in India also. So thank you everyone, Dr. Sun, Dr. Dong, and Dr. Ma for joining, Dr. M.K. Das for joining online and giving his introduction. Thanks to Dr. Belbir and Dr. Shastri, my co-chair, for making this session a very fruitful discussion. So thank you Asian Heart Society for this wonderful initiative. I think we will take this collaboration forward to greater heights. Thank you so much for joining. I think this is streamed live across all the Asian countries where we have you have sent us the link. I think people are watching elsewhere also. Thank you so much. Thank you everyone. So any comments from
Thank you.
Thank you.
Final comments from Dr. Dong or Dr. Sun? Anything?
Not really. So thank you very much for inviting me, and congratulations to the wonderful meeting. And we hope we can meet in China in the near future for AHS activities. Thank you.
Thank you. Thank you. Bye.
Thank you.
Bye bye.